Hello, Mamta team. Hello, Mamta. Anyone from Mamta team?
Yes, ma'am.
You will have to share the videos.
Yeah, sure.
Okay. Thank you.
Good morning, everyone, and a very warm welcome to the day 3 of this training program. And we have already discussed about the oxygen therapy and non-invasive ventilation, how to do non-invasive ventilation in children with COVID-19. We all know the importance of oxygen therapy and the invasive ventilation in children with COVID-19 infection. So today we are going to discuss about the invasive ventilation, when to ventilate, how to ventilate, the endotracheal intubation, the settings of ventilator, and we will try to stick to the basics. Okay. So I see that some of the participants are still to join. So we can wait for 2-3 minutes more, Manisha, and
Yes, ma'am.
then start. And
Yes.
a very happy Eid to all of you. And so that's why probably some participants are late. So just wait for a few minutes and then we'll start.
Yes.
So for today, our first speaker is Dr. Manisha Maurya, and she is associate professor at Allahabad, Prayagraj Medical College. And she will be talking about the basic terminology of invasive ventilation. So, Dr. Manisha, please start.
Thank you, ma'am. Uh, First of all, happy Eid to everyone. And as discussed by Dr. Chandrakanta, ma'am, we will be totally discussing on invasive ventilation today. And the first session is the basic terminology of invasive ventilation. Am I audible?
Yes, yes. And slides are visible too.
Okay, ma'am. Thank you. Now, the specific learning objectives of today's this session is concept of basic parameters of mechanical ventilation, parameters that control oxygenation, parameters that control ventilation, and video demonstration of how to set up a ventilator. And about the basic parameters, let us discuss one by one the settings which we set on a ventilator. First is the respiratory rate or the frequency. Respiratory rate is the number of breaths the ventilator will deliver per minute. So the initial rate which is set in on a ventilator of the respiratory rate is according to the physiological rate of the age. In the first session, first day, we all must have learned what is the physiological respiratory rate of children. It is slightly higher than adults. In neonates, around 40, and in infants, around 30, in children, about 25. Then in adolescent, maybe around 20. So we should always remember the physiological rate of the child and set the initial rate according to the physiological rate. And the intention of providing setting this respiratory rate is to provide eucapnic ventilation, that is normal carbon dioxide in ABG or in EtCO2. We should be titrating respiratory rate according to the PaCO2 level, as respiratory rate determines the minute ventilation, that is the product of tidal volume and respiratory rate, and thus it determines the carbon dioxide elimination. While titrating respiratory rate on seeing carbon dioxide, we must see that if the carbon dioxide has risen to such a level that it is causing respiratory acidosis, that is pH is around less than 7.2, or it has passed beyond the permissive hypercapnia, we may have to increase the respiratory rate so as to keep the carbon dioxide level towards the normal range. The next value is the tidal volume, which we set on a ventilator in a volume control mode. We set usually the tidal volume. The tidal volume is the volume of air delivered to the patient during a ventilatory breath. It is usually preset in a volume control mode, and it is variable in the pressure control mode, and it varies according to the lung compliance and the airway resistance in a pressure control mode. So in a pressure control mode, if we usually set the PIP, and we should monitor the tidal volume, and should be kept around the normal range, that is 6 to 8 ml per kg. The initial setting of tidal volume is kept around 6 to 8 ml per kg, and in ARDS we usually try to keep tidal volume towards the lower side, that is 6 ml per kg, as high tidal volume may cause lung damage in ARDS type of illness. And tidal volume also determines minute ventilation, as the product of minute ventilation is the product of tidal volume and respiratory rate. Now next is FiO2. FiO2 is the fraction of oxygen in the inspired air gas mixture. We usually set it between 21% to 100%, and its main function is to improve the oxygenation of the patient. And we try to adjust the value of FiO2 so as to keep PaO2 level and SpO2 level within the acceptable range, that is SpO2 between 92 to 94% and PaO2 between 60 to 80. And while seeing both these parameters, we should try to keep the FiO2 below 60%, as FiO2, a high FiO2 more than 60% may cause oxygen related lung damage. Oxygen toxicity may happen, free radical damage, inflammation, everything can happen. So we can start with 100% oxygen initially, but when the patient has stabilized by other parameters, we should try to keep the FiO2 below 60%. The most important parameter which we all set in ARDS is PEEP, that is positive and expiratory pressure. It is the positive pressure which is maintained at the end of expiration. The main function is to improve ventilation perfusion matching and oxygenation by decreasing the intrapulmonary shunt. Intrapulmonary shunt is the amount of blood which is coming from the heart to the lungs and is going unoxygenated again to the heart. So unoxygenated blood which is again reaching to the heart is the intrapulmonary shunting, which decreases the oxygenation status of the patient. By increasing the PEEP, we can decrease the intrapulmonary shunting, we can increase the ventilation perfusion matching, and thus we can increase the oxygenation status. PEEP also increases the functional residual capacity. Functional residual capacity, what is functional residual capacity? It is the amount of air that is left in the lung after normal exhalation. So there has to be some air left in the lungs after exhalation so that the alveoli may not collapse fully. So what the PEEP causes, the increase in functional residual capacity, thus it causes the distending of the patient's alveoli. It recruits the previously collapsed alveoli which was collapsed because of some illness in the lung, and thus improves the lung compliance and oxygenation of the patient. Now let us see this diagram. We are seeing three types of alveoli. This is a partially collapsed alveoli in which we have given a low PEEP. So we can see that in a collapsed alveoli, ventilation is not proper, but the perfusion, this dotted line is the perfusion. Perfusion is proper, but ventilation is not proper. So in this, we are seeing that there is ventilation perfusion mismatch. Now let us see this diagram. In this, we are seeing the alveoli is over distended. We have given very high PEEP. So this over distended alveoli, it causes compression of the perfusion. So although ventilation is good, but perfusion is hampered. Now let us see this diagram. In this, we have given optimal PEEP. So both perfusion and ventilation are good. So proper matching of ventilation and perfusion, thus increasing the oxygenation status of the patient. But while setting a PEEP, we should always keep in mind that high PEEP may cause overdistension of the lungs, thus decreasing the venous return coming to the heart. And this decrease in venous return may cause decrease in cardiac output and hemodynamic stability in the patient. So while keeping this, we always have to keep in mind. And high PEEP may also cause air leak by bursting the alveoli. It may lead to pneumothorax or pneumomediastinum. The initial setting which is kept of PEEP is 3 to 5 centimeters of water. In ARDS, we can start with high PEEP, that is 8 centimeters of water also. The next setting is the peak inspiratory pressure. We usually set this in a pressure control mode. It is the highest pressure which is reached during the inspiratory phase. PIP, that is peak inspiratory pressure, also improves the oxygenation. Inappropriately high PEEP may lead to air leaks and barotrauma. In volume control mode, sometimes we can see that there is sudden increase in PIP. It indicates that there is some airway resistance, and this airway resistance may be because of secretions, bronchospasm, and mucus plug. So if in a volume control mode, if we are seeing sudden increase in PIP, we should always go and look for any airway resistance and manage it. That is, if there are secretion, we can do suction, bronchospasm, we can do nebulization, mucus plug, we can decrease, we can nebulize with acetylcysteine and do suction. The initial setting of peak inspiratory pressure is kept around 18 to 20 centimeters of water. Now this is a simple diagram which can show easily that what is PIP and PEEP. Expiratory pressure which is maintained throughout the cycle which distends the alveoli, and peak inspiratory pressure is the positive pressure reached at each breath. Now plateau pressure, that is P plateau. P plateau is the alveolar distending pressure, that is pressure applied by the ventilator to the small airways and the alveoli. That is, for example, if we are giving a pressure, ventilator is providing a PIP, a peak pressure, but while coming up to the alveoli, some pressure is decreased. So the pressure that is reaching up to the smaller airways and the alveoli is the P plateau. It reflects the lung compliance. It is usually kept less than 30 centimeters of water. But we should always remember that we don't set a P plateau on a ventilator. We derive it. We derive it by doing an inspiratory hold maneuvers for 0.5 seconds. These inspiratory hold maneuvers are there in the tool section or the setting section of the ventilator. We can go on the tool section or the setting section, or there can be direct buttons on the ventilatory panel. We can do it for 0.5 seconds and we can derive the P plateau. It is always important to derive the P plateau in all cases of ERDS so that P plateau should not go beyond 30 centimeters of water. Now this diagram can easily show what is P plateau. We have given a pressure because of some airway resistance. The pressure which is reaching up to the alveoli is decreased, and this is P plateau, and we get this by doing a inspiratory hold. In volume control, in which we don't set a P peak and P peak, sometimes if we find the both P peak and P plateau has risen up, that indicates that the compliance is poor and the lungs are stiff, and that has to be seen and kept in mind. Now next one is the mean airway pressure. Mean airway pressure we usually don't set this. We don't set this on a ventilator, we derive it. it is the determinant of oxygenation status of the patient. It is the average pressure in the respiratory passage during the ventilation. And it can be also seen that is area under the pressure time graph. It can also be defined as the area under the pressure time graph. And the mean airway pressure is determined by PIP, that is peak inspiratory pressure, positive end expiratory pressure, ventilatory rate, TI, and the flow rate. So all these parameters affect the MAP. MAP can also be determined by the formula TI multiplied by PIP plus TE multiplied by PEEP upon TI plus TE, or we can derive it on a ventilatory display unit, that is typical MAP, which is kept around 5 to 20 centimeters of water. If we want to improve oxygenation, we can increase the MAP, and MAP can be increased by any of the 5 parameters, which can increase the area under the pressure time graph, that is the flow, the PIP, the TI, that is inspiratory time, PEEP, that is positive end expiratory pressure, and the respiratory rate. All these 5 parameters can increase the area under graph. So these parameters can increase the MAP and thus can increase the oxygenation status. The best among these is PEEP. Peak inspiratory flow rate, that is tidal volume upon TI. It is the maximum speed at which the tidal volume is delivered by the ventilator, and it is expressed in liters per minute. The higher the flow rate, the faster the peak airway pressure is reached and the shorter is the inspiration. If we set a lower flow rate, then it will be a longer inspiration. In volume control mode, we can set peak inspiratory flow rate, but in some ventilators, we don't find this setting. And in those ventilators, the peak inspiratory flow rate is usually set at a default of about 60 liters per minute. We can set peak inspiratory flow rate from around 30 to 100 centimeters of water. IE ratio. IE ratio is the ratio of inspiratory time upon expiratory time. Normal IE ratio is around 1:2. IE ratio, while setting a IE ratio, we usually, what we set on a ventilator is the inspiratory time and the expiratory time. So while setting an inspiratory time and an expiratory time, we should always keep in mind that the IE ratio should be around 1:2. So this inspiratory time, while we are setting an inspiratory time, it should always be kept at the physiological as possible. The physiological inspiratory time of a neonate is around 0.3 to 0.4, of an infant is around 0.4 to 0.6, of less than 5 year 0.6 to 0.8. Over that, about 0.8 to 1, and in adults and above, around 1 to 1.2 or 1.4 also. The inspiratory time can increase the oxygenation as it is also a determinant of mean airway pressure. So while if we are increasing the inspiratory time to increase the oxygenation status, it can cause decrease in carbon dioxide elimination as the expiratory time is also decreased, and may cause air trapping and hyperinflated lungs, which is also not good. And if we want to improve the ventilation, we can increase the expiratory time, as in the case of obstructive diseases like bronchial asthma, in which we need to increase the expiratory time. While increasing the expiratory time and causing the carbon dioxide washout, sometimes high TI may also cause atelectasis. So both these things can be kept in mind. So if we are increasing the oxygenation, if we want to increase the oxygenation, we can also keep the IE ratio around 1:1, but this should be the last parameter. If we have done everything, then only we should keep this IE ratio around 1:1. And sometimes if we want to have more expiratory time, like in bronchial asthma, we can keep the IE ratio around 1:2 or 1:3 also. 1:3 to 1:4 also. Too less TI in case of volume control mode can lead to set tidal volume being delivered too quickly, and it may result in high pressure being reached too early, and this sudden increase in high pressure may cause lung damage. And if there is too long TI, which will limit the respiratory rate, thus it may also cause hypercapnia. So these things should be kept in mind. Now let us see the phase variable upon which a basic ventilator works. The three phase variables are the first one, this is A, trigger, that is what initiates the inspiration. B is the limit, what regulates the gas flow during the breath. And C is what causes the breath to end and start exhalation. So these are the basic phase variable upon which a ventilator works. Now let us see one by one the trigger. Trigger is what determines the start of inspiration. It can be of three types: time triggered, pressure triggered, and flow triggered. Time triggered is usually the ventilator triggered. That is, a breath is delivered once the preset time has been elapsed. That is, according to the set frequency. Let us, for example, if we see we have set a frequency of about 20, then the ventilator will deliver each breath at 3 seconds. So it is seen in controlled mandatory ventilation. We will be discussing later in the coming session. So time triggered is basically the machine triggered. Next is the pressure triggered and flow triggered. Both these are patient triggered. Patient starts the initiates the inspiration, and ventilator senses that inspiratory effort and then assists that inspiratory effort. So what is pressure triggered? Ventilator senses the patient's inspiratory effort in the form of decrease in baseline pressure. As we all know that during inspiration, there is negative pressure created. So this effort, the patient's effort of decreasing pressure in the chest is sensed by the ventilator, and this inspiratory effort is now assisted by the ventilator. So this is pressure triggered. And flow triggered is the ventilator senses the patient's inspiratory effort in the form of decrease in baseline flow. That is, if during exhalation there is a decrease in baseline flow, so we can see that this decrease in baseline flow or direct the inspiratory flow ventilator can sense, and thus can assist that inspiratory effort directly. So this is, both these are patient triggered. Patient initiates and triggers the inspiratory effort which is sensed by the ventilator, and thus ventilator now assists that inspiratory effort. Limit. Limit is what regulates the gas flow during the breath. If a variable, for example, if we see pressure, flow or volume, in pressure we set a PIP, that is beyond that pressure, peak inspiratory pressure throughout the cycle in a pressure limit mode, the pressure will not go beyond the whole breath. And if, for example, if we see volume control mode, we set a tidal volume. So if it is volume limit, the tidal volume will not go beyond that limit. So if a variable is not allowed to rise above a preset value during the inspiratory time, it is termed as limit variable. The breath delivery continues, but the variable is held at a fixed preset value. Now cycle. Cycle is what ends the inspiration. Let us see against this diagram. This is limit and this is cycle. Cycle is what ends the inspiration and starts the expiration. Cycle is also of three types. That is volume cycle, pressure cycle, and time cycle. Volume cycle is inspiration ends when a preset tidal volume has been delivered. Pressure cycle is inspiration ends when a specific airway pressure is achieved. And time cycle is inspiration ends when a preset time has been elapsed. For example, if we set a TI of about 0.4, so after 0.4 seconds, the expiration will start and the inspiration will end. Most of the pediatric ventilators are time cycled and flow triggered. So after a particular time, the inspiratory time which we set, maybe around 0.4 to 0.5 seconds, the inspiratory breath will stop, and now exhalation will stop in a time cycle, and flow triggered, that is patient inspiratory flow rate is sensed by the ventilator, and then that inspiratory effort is assisted by the ventilator. Now what are the practical applications? These settings, either we want to increase the oxygenation status or we want to determine the ventilation. So the cases, the examples in which we want to increase the oxygenation is either pneumonia or ARDS, in which PaO2 level, we have to see the PaO2 level or SpO2 level. PaO2 level, as we had discussed earlier yesterday, that is around 80 to 100 centimeters of water. So if the PaO2 level has fallen low, that is maybe around 50, we have to increase the oxygenation status. So for increasing the oxygenation status, we can increase either mean airway pressure or FiO2. So both these parameters can be increased, and we have discussed earlier that MAP, for increasing MAP, either we can increase the flow rate, we can increase the BIP, we can increase the PEEEP, we can increase the TI, that is inspiratory time, or we can increase the respiratory rate. So either of the five parameters which determines the MAP can be increased, and the best among them is PEEEP. So if we want to increase the oxygenation status, we can increase MAP, and we can increase PEEP and the other parameters which can determine MAP. So for ventilation, we have to see PaCO2 level for proper ventilation in cases in which there is poor ventilation, as in case of apnea or in case of neuromuscular blockage like GB syndrome, or in case of CNS depression, or in case patients' efforts are very poor in which ventilation is not taking place. Carbon dioxide retention can occur, and for removing the excess of carbon dioxide, that is normalizing the PaCO2 level, we can either increase the tidal volume or we can increase the respiratory rate. Among these, we usually use the respiratory rate, as increasing the tidal volume may also increase the pressure, and increased pressure may cause lung damage or barotrauma. Now let us see this diagram. This is a diagram of a basic ventilator. We have to connect the ventilator to the oxygen panel and the compressed air panel. In the new ventilators, we usually don't have this compressed air panel. We have an air compressor here. Air compressor provides the compressed air, and air gas mixture is mixed in the ventilator. So we get a FiO2 by mixing the air and gas, both percentage of fraction of oxygen. So this is a ventilator panel. There are three electric supply, one for ventilator, one for compressor, and one for UPS. We have to keep in mind that we have to connect all these things to the electric supply. Here we can attach the humidifier. This is the breathing circuit. One is the inspiratory limb and another is the expiratory limb. Very easy to understand. And this is a flow sensor. We can attach a HME filter if we are not using a humidifier, that is heat and moisture exchange filter can be kept. But while attaching this HME filter, we have to keep in mind that we have to keep it according to the pediatric age, not larger, because larger one can increase the dead space. And this is the test lung that is attached to just test whether the ventilator is functioning properly or not. We can attach the flow sensor which senses the various parameters of the ventilator. This is the simple breathing circuit or breathing assembly. Patient inlet which is coming from the ventilator, we can attach a bacterial filter. Then it goes to the inspiratory limb, comes from the ventilator, goes to the humidifier. From the humidifier, heated and humidified. Heating around body temperature, that is 37 degrees, and humidification around 100% has to be done. Then the inspiratory limb, heated humidified inspiratory limb comes, attaches to the eyepiece. There is a water trap in between, so that water vapor doesn't collect in the tube, which can increase the airway resistance. And then through this, we can attach nebulizer. If we want to nebulize the patient, we have to attach the flow sensor. Nebulizer is only optional. We can remove it if it's not required. We have to attach to the flow sensor. We can attach HME filter if we are not using humidifier. Then through this HME filter, we can directly connect either through the NIV mask, that is non-invasive BiPAP mask, or we can attach to the endotracheal tube. From the patient, the exhaled air comes through the eyepiece. Exhalation limb is there. It goes again to the ventilator. This is the simple display unit of a ventilator, in which there is a on-off button. There is an alarm button. We have to set alarms of every parameter, so that beyond which, if the ventilator is by chance delivering, we can go and see what is the problem and manipulate. This is the knob, rotatory knob, through which we set various parameters. These are the blue squares in which we set the various parameters, and these black squares are the readings which we derive from the ventilator. These are not set. These are the various graphs, scalars, that is pressure time and the flow time. We can also have volume time and volume pressure graphs also. These are the references. And the skills which has to be enhanced is it is important to understand and set all the parameters. Changes in these parameters should be done according to the patient's clinical status and ABG. And further practical implication will be discussed in the mode section, and the initial titration setting and the titration will be discussed further. My sincere thanks to all the contributors, to Chandrakanta ma'am, to Shali ma'am, DGME sir, and all the panelists here, all the attendant, all the participants for keen hearing. Thank you very much. But before that, I will be just requesting Mamta team to kindly show the videos. Mamta team. This one.
Hello everyone, today we will see about the mechanical ventilator, the parts of the ventilator, tubings, how to attach these tubing and how to start a ventilator, and the next part we'll see how to set the parameters for the pediatric patient. So this is the electronic ventilator which we are using in our ICUs. This is the main panel of the ventilator. Currently this is switched off. We have to switch on the ventilator from the back side. After connecting the charging port into the cable into the charging port, and also the humidifier, and we'll connect the cable of the humidifier to the port, and we'll start the ventilator. This will see the charging cable, lights of the charging cable are on. This is the button from which we'll start the ventilator. We'll press it for the long time and we'll see the main panel is getting displayed. It will take some time to for the main screen to come. Till the meantime we'll attach the tubings. So as all the ventilator we know, we have some basic tubings. We'll take the sterile tubing, either the fresh tubing which are coming in the market or the reusable tubing which have been ETO'd or sterilized. So after donning gloves and hand washing and donning gloves, we'll take out the tubing. This part which has a 3 plug, this is the expiratory tube. So these are the tubings. It has both inspiratory and expiratory part. So how to differentiate? The one with a thin, the white tubing generally with a thin inlet is the expiratory tube, and the blue one, other one is the inspiratory tube. So as we see, this is the attachment which goes on the patient end in the endotracheal tube, and this is the end which goes into the ventilator. So we'll start with the humidifier chamber. So this is the humidification chamber, which will, as we can see, there is a line which gives us the level for the water, and only sterile water or distilled water is filled in the chamber. So this is our humidifier. We'll switch on the humidifier from this point. We'll push down the inlet and then gradually slide it down. So as a click sound has come, that means the chamber has properly fixed. Now we'll attach the tubings. So this port, this is expiratory port, and this is clearly mentioned is here is expiratory. So the expiratory port will goes into this. The second part, which is the short part of the inspiratory tube. So the one part goes into the inspiration as mentioned in here, like this, and the broad part goes into the humidifier chamber. So we'll put the humidifier chamber. This is the inspiratory port which is going from ventilator to humidifier. Second part will come from humidifier to the patient end. So this is the second part of the inspiratory limb. From humidifier, the broad end will goes into the humidifier chamber, and the second part into the patient limb. For timing, we'll attach the patient limb to the test lung. There is one more tube which is oxygen tubing. This is attached from this proximal end of the ventilator up to the distal end of the expiratory limb. This is the point. Okay, so this is our tubing. Now comes the humidification. So for the how to attach the humidifier, since we have seen, we have switched on the humidifier, it is showing us the temperature. These are two modes, the invasive mode and non-invasive mode. Since we are doing the invasive ventilation, we'll select the invasive mode, and these two wires are there. So where to connect which wire? Since there are 3 ports, as you can see, we'll connect this proximal end into the inspiratory one, like this. The second part goes into the expiratory limb here, upside. Now the second tubing, the below one, as you can see, it has a blue point and has a cone-like thing here. So this cone get attached into the inspiratory limb. As you can see, there is a conical part for this blue thing. So we'll attach it here like this. Next comes its distal part. This is conical form, and this get attached into the inspiratory limb. So our inspiratory limb is humidified and heated. Now coming to the ventilator. So after attaching to the main source, we'll attach the air and oxygen. So from behind, please come behind. So and on the back side of the ventilator, as you can see, it's clearly mentioned the oxygen port and the air port. So when we'll trace down the air port, this white port is the oxygen port. So as we'll see, this white tubing will connect into the oxygen like this. We have to plug it down and then push. Similarly, air will plug it down and push. Second thing which we will see on the back side is the flow sensor. So from here, the flow sensor wire is connected, and it is then connected on the patient end like this. Now we'll start the ventilator. As we have switched on, this is the first screen which we see on the ventilator panel. We'll see the audio test. It is making sounds. Yes, we are able to hear the sound. Now here comes the second screen. Now we have to select which are we dealing with, the pediatric, like neonatal age group, or pediatric age group. So if we are here dealing with the neonatal age group, less than 10 kgs, well, and it's about the flow sensor. So how to calibrate the flow sensor? So we'll take the flow sensor, we'll block both of its end or with our palm, and then do the flow calibration. So as you can see, a green line has came and is saying it's calibrated. We'll go on the main screen. I will connect it back. So this is the main panel. On main panel, you can see there are multiple things which is coming, and these are the modes. On baseline, you can see there CPAP, nasal CPAP, dose CPAP, oxygen therapy. These are basically non-invasive modes, and the upside is control mandatory ventilation, assist ventilation, SIMV plus PSV and PSV. These are basically the invasive modes which we can give in the patients. Depending upon the modes, there are the control panel. There are the parameters which we can control, like the flow, trigger, I time, E time, the frequency, this FiO2, PIP and PSV, PEEP, oxygen, and volume limit. And this is the graph we can see depending upon what parameters we are seeing, whether the pressure, volume, or flow. So one by one, I'll tell you what settings which we are needed to set for different parameters.
Mr. Neeraj, there is one more video. Yes, this
वेंटिलेटर है, और ये हमने इसमें सर्किट और टेस्ट लैब तैयार करके रखा है। मैं आपको दिखा दूं, ये फ्रॉम द पेशेंट दैट इज एक्सपिरेशन, एंड ये टू द पेशेंट दैट इज इंस्पिरेशन। ये फ्लो मीटर ये लगे हुए हैं, ये वेरी सिंपली इट अटैचेस हेयर है स्पायरोमेट्री के, ये यहाँ लगे हुए हैं स्पायरोमेट्री। ये लाइन यहाँ अटैच्ड है, यहाँ पे हमने फिल्टर अटैच कर रखा है और ये टेस्ला में अटैच है। अब मैं आपको बताऊंगा कैसे इस वेंटिलेटर को आपको ऑन करके चलाना है, यूज़ करना है एग्जैक्टली। तो इस वेंटिलेटर में आपके पास दिस इज द कंप्रेसर एंड दिस इज द यूपीएस। इन दोनों को बिजली की सप्लाई देनी है, करंट की सप्लाई देनी है, और ये है वेंटिलेटर। इन तीनों को करंट देना है हमको। वेंटिलेटर अपना करंट यूपीएस से उठाता है, तो वेंटिलेटर का जो सर्किट है वो यूपीएस पे लगा हुआ है। कंप्रेसर और यूपीएस, इनका कनेक्शन हमने यहाँ दे रखा है। ये यूपीएस के लिए है, ये कंप्रेसर के लिए है, और वेंटिलेटर की इलेक्ट्रिक करंट वो यूपीएस से आ रहा है यहाँ पे नीचे इस पॉइंट से। ठीक है, तो आपको दो आउटलेट लगाने हैं और वेंटिलेटर का इनलेट आपको यूपीएस से लेना है। अब इसको कैसे ऑन करना है? ऑन करने से पहले मैं इसे ऑफ कर देता हूँ। वेंटिलेटर बंद हो गया। ठीक है, आपने कनेक्शंस दे दिए, आपने बटन ऑन किए। आप आएंगे यहाँ पे, पहले बटन को ब्रीफली प्रेस करेंगे। पहले यहाँ से कंप्रेसर को ऑन करेंगे और यहाँ से फर्स्ट बटन को ब्रीफली प्रेस करेंगे फॉर 10 सेकेंड्स। यहाँ पे आ जाएगा वोल्टेज 230 वोल्ट्स का। वेंटिलेटर की मेन स्क्रीन पे आएंगे, यू विल कंप्रेस इट, सेल्फ ट्रेस्ट एंड कैलिब्रेशन होगा। पास नॉब को प्रेस करेंगे, स्टार्ट दबाएंगे, स्टैंड बाई मोड पे है। अपना मोड सेलेक्ट कर लेंगे, आप जो भी मोड यूज़ करना है आपको। सपोज आपको हमें प्रिंसिपल मोड यूज़ करना है अपने मोड के लिए, आपने स्टार्ट कर दिया और इंश्योर करना पड़ने के लिए कंफर्म कर देंगे, ये स्टार्ट।
So both this second one was a ventilator which was supplied by PM Cares, which may be supplied to all in which COVID care centers will be there. So if someone is not able to understand these videos, one can ask the technician who is supplying the ventilator to come and demonstrate how to set up a ventilator. So it's not very difficult job. We can easily understand how to set up a ventilator by just asking the technician of that ventilator. He will come and display us. Thank you very much.
Thank you, Dr. Manisha, for such an informative talk. And I think all of us are now aware about the basic terminology of ventilation. So thank you, Dr. Manisha. And with ventilation, we need to monitor the child. So properly is monitoring is must. So our next talk is about the multi-para monitor. Come talk is about the multi.
Hello, thank you, ma'am. Good afternoon to all the attendees.
Multi-para monitor. Dr. Anupma
Hello. Hello.
You are audible, Dr. Anupama.
Yeah. Oh, okay. Okay. Thank you, sir. Sir, but I'm not able to share my content. Only the host can share in this meeting.
So then ask Mr. Neeraj.
Neeraj, please allow me to share my screen.
You can share it now.
Okay. Thank you.
Is there any problem?
Yes, ma'am.
So, I think Mamta team can show your presentation.
Okay, ma'am. Okay.
They can project.
Okay, ma'am.
Mamta team, please project the talk of Dr. Anupama on multi-para monitor.
Yes. Thank you. For the next 30 to 40 minutes, we will be discussing about multi-para monitor, which is an important aspect. We should know about multi-para monitor while working in ICU. Our learning objectives will be different monitoring parameters, how to use it, what should be our alarm setting, and what should be the maintenance of multi-para monitor. Next. Simultaneously measure and display of relevant vital parameters in a sick child. What does the multi-para monitor do? उस टाइम पे ही measure करके और values graphic, either graphic or a numeric display is there. In general, basic models are used to monitor cardiac activity, heart rate, oxygen saturation, invasive and non-invasive blood pressure, respiration, and temperature. It consists of 4 components: sensor, जो body से attach होता है, then there is a communication link, then followed by a processing device, and finally a display, either in a numeric value or in a graphic or both. Additional specifications are according to the model and makers, and there are multiple brands available. Like common ones are the Minray, GE, Philips, Draeger, and other. Next. What should be our monitoring domains? In cardiology, we have ECG, cardiac output, continuous cardiac output monitoring, impedance cardiography. For hemodynamic, oxygenation and volumetric, we have invasive and non-invasive blood pressure, central venous saturation, SpO2, perfusion index. Airway and lung mechanics, we have respiratory mechanics. For tissue perfusion, we have regional saturation. On and other, for neurology, we have EEG, NMT, and temperature. Next. The red one are the common parameters like ECG, respiratory rate, SpO2, temperature, invasive and non-invasive blood pressure, central venous pressure, and ETC, end tidal CO2. The red ones are the common ones, and we will be taking up one by one in the next slides. And the other red one are the lesser used one, but we should know something about them. Like EEG, regional oxygen saturation, cardiac output, CC, central venous oxygen saturation, neuromuscular transmission, impedance cardiography, bispectral index, respiratory mechanics, and transcutaneous blood gas. Next. First one is the ECG. We can use either of these, either 3-lead ECG, 5-lead, 6-lead, or 12-lead, selectable depending upon the patient condition and our level. Heart rate, we get it from ECG or by SpO2. Arrhythmia detection is very easy just by looking at the ECG. We can diagnose many arrhythmias just by looking at the waveform of the ECG, and many electrolyte imbalance can also be just detected early just by looking at the waveform of the ECG. Next. This is 3-lead वाया इलेक्ट्रोड प्लेसमेंट, जो सबको आना चाहिए कि कोई भी पेशेंट जब भी इमरजेंसी में लैंड करता है तो एटलीस्ट उसे 3-lead ECG हमें तुरंत स्टार्ट कर देना चाहिए. तो 3-lead ECG प्लेसमेंट आइडियली सबको एक्नॉलेज है कि रिफ्लेक्स में रहना चाहिए हमेशा. तो इसमें 3 लीड लगाने होते हैं. सबसे पहले जो है दैट इज LA लीड. LA लीड इज स्पेस जस्ट बिलो द लेफ्ट क्लेविकल नियर द लेफ्ट शोल्डर. सेकेंड इलेक्ट्रोड जो हम अटैच करेंगे दैट इज RA1. RA कहाँ लगाना है? जस्ट बिलो द राइट क्लेविकल नियर द राइट शोल्डर, और एक नीचे लगाना है लोअर एब्डोमेन पे, लेफ्ट लोअर एब्डोमेन पे. तो 3 लीड आते ही पेशेंट को एकदम से अटैच कर देना है. और उसके बाद जो है ये बेसिक वेव फॉर्म दिया हुआ है. बेसिक वेव फॉर्म इज इजिली विजिबल ऑन द स्क्रीन. लगाते ही आपका एक हार्ट रेट आने लग जाएगा मॉनिटर पे और एक वेव फॉर्म आने लग जाएगा. तो दिस इज द नेसेसिटी. कोई भी पेशेंट आता है एटलीस्ट 3 लीड ECG लगा दीजिए और वो एटलीस्ट मॉनिटरिंग स्टार्ट हो जाती है पेशेंट की. Next. Next domain is respiratory rate. Next. We can derive respiratory rate either by the CO2 monitoring or by the impedance, which is again वही ECG leads जो होती हैं वही आपके impedance के through respiratory rate दिखाते हैं उस पे monitor पे. Next. These are this either lead one जो है उसमें that connect LA and RA, lead one, और line connecting to RA and LL is lead 2. Either of the lead can be used to monitor the respiratory rate. Next. Next is pulse oximetry. Most talk about thing in the COVID era. सबको पता है saturation कितना चल रहा है, ऑक्सीजन लेवल कितना चल रहा है, एक लेमैन भी को पता होता है. तो बेसिकली 4 डोमेन्स होते हैं इसमें सैचुरेशन मॉनिटरिंग में. फर्स्ट इज SpO2 जो सबको पता है, इवन लेमैन को भी पता है कि सैचुरेशन इतना आ रहा है. दूसरा परफ्यूजन इंडेक्स. थर्ड इज प्लेथिस्मोग्राफी वेरिएबिलिटी इंडेक्स, एंड फोर्थ वन इज द सिग्नल IQ इंडिकेटर. नेक्स्ट. SpO2 measures the oxygen saturation. Our target saturation should be more than 92. ये थोड़ा सा अलग है. Adult में हर जगह 94 वैल्यू थी, पर in pediatric will be using target saturation as 92. Avoid hyperoxemia in newborn, which is very important. जितना ज्यादा hypoxia damaging होता है उतना ही ज्यादा hyperoxemia damaging होता है in newborn में. तो newborn में जो target रहेगा saturation should be between 90 to 95, not more than 95. ये भी ध्यान रखना है, ज्यादा भी नहीं जाना है saturation, especially in newborns. There is a numeric and graphic display of saturation, and probe placement should be in the right upper hand in units. Preductal लगाना है. Avoid in limb in which the BP is measured. क्योंकि intermittent BP measures के लिए कफ इन्फ्लेट होगा. There is a decreased flow in the arterial wall. Unnecessary false reading आएगा, unnecessary attention जाएगा उस रीडिंग पे बार बार. तो उस लिम्ब में नहीं लगाना है जिसमें कफ बंधा हुआ है. Changing of probe site is very important, and ear probes are also available. Ear probes basically वहां पे यूज होता है जहां पे आपका ना peripheral saturation poor है, जहां पे SpO2 monitor रीडिंग नहीं ले रहा होता है, वहां पे हम ear probes यूज कर सकते हैं. They are available in markets. Next. 2 new terms for many of us, like perfusion index and plethysmography variability index. Perfusion index क्या होता है? It is basically an indicator कि पेरिफेरी में कितना ब्लड फ्लो हो रहा है. एक इससे एक आइडिया लग जाता है कि पेरिफेरी में सैचुरेशन तो ऑक्सीजन कंटेंट बताएगा आपको, और पेरिफेरी में ब्लड फ्लो कितना हो रहा है, that we can assess by the perfusion index. It is measured by the strength of the photoplethysmography signal at the sensor site. It compares the pulsatile to non-pulsatile signal, and value जो होती है that varies from 0.02% to 20%. 0.02 का मतलब क्या होता है? That is very weak pulse, और 20% higher value very strong pulse. इसी के साथ एक और टर्म आती है that is plethysmography variability index. It is same. It is क्या कहते हैं, this perfusion index, but it measures the change in the perfusion index during a respiratory cycle. ये कहाँ यूज, वैल्यू कैसे आती है, मैक्सिमम माइनस मिनिमम अपॉन मैक्सिमम से डिराइव करते हैं, और बेसिकली वॉल्यूम फ्लूइड दिया है, फ्लूइड स्टेटस के बाद आप असेस कर सकते हैं पेशेंट को फर्दर बोलसेस देने नहीं देने हैं. पीवीआई मोर देन 14% शोज गुड रिस्पॉन्स टू फ्लूइड लोड एंड कैन प्रिडिक्ट फ्लूइड रिस्पॉन्सिव इन इन्फेंट अंडरगोइंग कंजेनाइटल हार्ट सर्जरीज. जैसे ये ग्राफ है, ये मॉनिटर है, और इसमें मॉनिटर में जो गोला करा हुआ है दैट इज बाय द पर्पल लाइन 1.1. दिस इज परफ्यूजन इंडेक्स ऑफ द पेशेंट. नेक्स्ट, इससे पहले वाला, हाँ, थैंक यू. दिस इज सिग्नल आईक्यू इंडिकेटर. व्हाट इज सिग्नल आईक्यू इंडिकेटर? इट इज अ क्वालिटी ऑफ फ्लो टू द एरिया अप्लाइड एंड हेंस द सिग्नल क्वालिटी. बेसिकली जितनी ये न्यूमेरिक वैल्यूज आ रही हैं, एक ये सिग्नल को रीड करती हैं. तो जो सिग्नल आपका आ रहा है, जो मशीन रीड कर रही है, वो अप्रोप्रिएट मतलब आ रहा है नहीं आ रहा है, वो हम डिटरमाइन करते हैं बाय द सिग्नल आईक्यू इंडिकेटर. कई बार वीक इंपल्सेस होती हैं, फॉल्स रीडिंग आ रही होती है मॉनिटर पे, तो आपको एक हैबिट में भी होना चाहिए, आप सिग्नल आईक्यू इंडिकेटर भी देखते रहें साथ में. अगर सिग्नल आईक्यू इंडिकेटर आ रहा है, उसके साथ जो वैल्यूज है दैट आर ट्रू वैल्यूज. तो सिग्नल आईक्यू इंडिकेटर कैसे दिखता है? जैसे इसमें ये नीचे रेड मार्क में दिखा हुआ है, इट इज अ हॉरिजॉन्टल लाइन एंड इंटरप्टेड, बीच बीच में ये वर्टिकल लाइंस होती हैं. एक हॉरिजॉन्टल, ईच वर्टिकल लाइन कॉरेस्पॉन्ड टू ईच इंपल्स बाय द आर्टरियल वॉल. तो ये अगर इन रेगुलर फ्लो में आ रही है, तो दैट मींस आपका आर्टरियल इंपल्स एक रेगुलर वे पे वो रीड कर रहा है मॉनिटर. तो normal, this represent good, the good signal is present, and hence the signal IQ indicator is this good in this monitor. Next, these are the few example of signal IQ indicator and the plethysmography. सबसे पहले सबसे ऊपर वाला देखते हैं. इसमें क्या है, ऊपर वाला प्लेथिस्मोग्राफी है, जो वेव फॉर्म है. उसके बाद सिग्नल आईक्यू इंडिकेटर है, जैसे हमने पहले देखा था, बिल्कुल वैसा ही है, सेम वर्टिकल लाइन, हॉरिजॉन्टल लाइन, और उसके बीच बीच में वर्टिकल लाइन, दैट इज एट रेगुलर इंटरवल. और उसके साथ एक रीडिंग है, सैचुरेशन इज 94, ये परफ्यूजन इंडेक्स है, इधर हार्ट रेट आ रहा है दैट इज 179. हमारा इन्फ्लुएंस इसमें क्या निकलेगा? नेक्स्ट, दैट मीन्स गुड SIQ विद गुड प्लेथिस्मोग्राफी. फर्स्ट वाले का हमारा इन्फ्लुएंस के है. अब सेकंड देखते हैं. सेकंड में क्या है? इसमें वर्टिकल लाइंस नहीं है, एब्सेंट हैं, तो दैट मींस दिस इज पुअर SIQ, है ही नहीं. सिग्नल इंपल्सेस वेरी बैड and this waveform is very irregular, so inconclusive plethysmography. So these reading which is showing on the monitor can be a false reading. We should read it very cautiously. In the third one, we have a good SIQ indicator. नीचे जो horizontal line के ऊपर vertical lines regular interval पे है, but variable plethysmography ऊपर नीचे जा रहा है, तो this is our inference will be good SIQ with variable plethysmography. सबसे लास्ट नीचे फोर्थ वाले में क्या है? फोर्थ वाले में there is good SIQ but low volume this plethysmography is there, so it is non-variable, no plethysmography. So just by looking at the signal IQ indicator we can see मतलब कि false value तो नहीं है, actual impulse जो है वो actual read कर रहा है नहीं कर रहा है, तो it is very easy just by looking at this vertical lines on the monitor. Next. Next important parameter is temperature. Next. It is thermally sensitive resistors are used. The resistance change of thermistor are used to calculate the temperature. Up to 2 temperature sites can be monitored simultaneously, and the difference between the two sites is calculated. Rectal temperature monitoring is also possible with spatial probes, generally used in severe hypothermia or in severe acute malnutrition patient. Next. Next important parameter is non-invasive blood pressure monitoring. Next. Non-invasive blood pressure monitoring is measured by the oscillometric method based on the principle that the pulsatile blood flow through an artery creates an oscillation in the arterial wall. एक oscillations, ये graphs side में उसमें भी there are oscillations in arterial impulse. ये oscillations को ही basically read करता है. इससे जो एक्चुअल मेजर करेगा दैट इज द मीन ब्लड प्रेशर. जो NIBP से वैल्यूज मिलती है, तीन वैल्यूज मिलती हैं, सिस्टोलिक ब्लड प्रेशर, मीन ब्लड प्रेशर एंड डायस्टोलिक ब्लड प्रेशर. इट एक्चुअली मेजर्स द मीन ब्लड प्रेशर एंड सिस्टोलिक एंड डायस्टोलिक ब्लड प्रेशर इज डिराइव्ड फ्रॉम द मीन ब्लड प्रेशर. तो ये बीच वाला जो है दैट इज मीन ब्लड प्रेशर इज एक्चुअली मेजर्ड एंड अदर्स वैल्यूज आर डिराइव्ड फ्रॉम इट. नेक्स्ट, some important points while taking this BP. We should always determine the limb circumference to get the appropriate size of BP cuff. अगर छोटा BP लेंगे तो ज्यादा BP आएगा आपका. छोटा कफ साइज का अगर वो BP कफ यूज करेंगे तो बड़ा ज्यादा आएगा, बड़ा हुआ. अगर बड़ा कफ यूज करेंगे तो BP आपका कम आएगा. तो हमें बहुत ही ध्यान से BP कफ का डिसाइड करना है. The width of the cuff should be 40% in units and 2/3 of the length of the upper arm or thigh in the children. The inflatable portion, that is the bladder portion, जो inflate होता है, that should cover 60 to 80% of the arm. Application of cuff should be such that the artery marking, एक artery marking होती है जो cuff बांधते हैं, depicted by an arrow, should be at the appropriate place. It should be smooth and snugly fitting, and we should choose an auto deflation mode. Ideally, average of 3 readings should be taken, and we should avoid taking BP in crying or agitated child. Unnecessary बड़ा हुआ BP आ सकता है कोई भी रोते हुए बच्चे में या परेशान बच्चे में अगर BP लेंगे तो. Next, these are the various neonatal disposable BP cup. Size 1 to 5 are available in the market, and these are the different neonatal this cup of BP. Next. Next is invasive blood pressure, that is arterial blood pressure. Gold standard measure of taking blood pressure is invasive blood pressure. Next, but it is not it is used in critically ill patient or for real time recording, and both numeric and waveform can be taken from the invasive blood pressure monitoring. Next, this is this. Actually, we required an intra-arterial line for having this intra-arterial blood pressure monitoring. This in the arms we have. I cannot have arrow. There is intra-arterial catheter which is attached to a 3-way valve, and then 3-way valve is connected to transducer. This 4 number depicts the transducer, and this transducer is connected to the IB cable, and IB cable is connected to the module. ये जो box जैसा part है that is IB module, और ये जो module है यही fit होता है आपके उसमें monitor में. So this is a pictorial depiction of this invasive blood pressure. Next, this is invasive blood pressure. This is pressure bag filled with 500 normal saline, connected to an IV line. Again, there is a transducer. Transducer is connected to cable, and cable is then connected to, और ये जो cable वाला part है finally वो module में fit हो जाएगा आपके. Next, important points is patency. Soft tubing of a bag of NaCl containing 500 ml of flush solution should be placed in the pressure bag. जो हमने देखा pressure bag attach होता है, and pressure of 300 inflated to a pressure of 300 millimeter of mercury. Labeling is very important to minimize the effect of hydrostatic pressure on the transducer. Too high, lower pressure, abnormally low pressure is there. Too low, greater pressure, abnormally higher pressure is there. Zeroing is important to negotiate the influence of external pressure on the monitoring system. जो atmospheric pressure, बाकी सारे जो pressure है that it nullifies by zeroing this intra-arterial BP monitor. Next. These are the components of arterial waveform. The peak one depicts the systolic blood pressure, 3 depicts the diastolic blood pressure, and 2 is the diachronic notch we get in this normal waveform of blood pressure. Next. Last parameter which we'll be talking about today is EtCO2 and tidal CO2. Capnography is a graphic display of CO2 concentration versus time, that is time capnograph. When the CO2 concentration is versus expired volume, we called it volume capnogram during a respiratory cycle. Capnography is a machine that generates a waveform और जो वेव फॉर्म हम देखेंगे आगे उसमें भी है, स्लाइड्स में भी है, उसे बोलते हैं कैप्नोग्राम. Why EtCO2 monitoring is important? EtCO2 monitoring is important because it depicts the ventilation part. SpO2 will tell us the oxygenation part and EtCO2 will tell us the ventilation part. The alveolar arterial जो exchange हो रहा है उस पे ventilation वाला part को वो depict करता है. अगर if there is any change in the ventilation, there is a sudden fall in EtCO2 value. Within few seconds we get change in the waveform, we get change in the numeric value of EtCO2. और वेंटिलेशन के बाद ऑक्सीजनेशन फॉल करने में इट विल टेक फ्यू मिनट्स. तो EtCO2 इज अ मोस्ट सेंसिटिव मार्कर फॉर दिस वेंटिलेशन पार्ट ऑफ पेशेंट. नेक्स्ट. This is through a Krebs cycle, CO2 is produced at the cellular level. It is an end product. CO2 is then taken up by the circulation. Then it goes through the right side. Then it pumps to the left side, and the heart pumps out. And then it reaches the respiratory part. Hence, EtCO2 will also depict the cardiac output. एक ना आपका assessment भी होता है कि अगर CO2 value से आप ये भी देख सकते हैं कि cardiac output कितना है patient का, एक amplitude जो capnograph का आएगा. Then it's taken up by the lungs. From lungs it comes out of the body, and from body it's reads up by the sensor which is attached to the body, and it gives the value. ये जो capnogram है waveforms देख रहे हैं, and this is 34 is the EtCO2 value, and this 15 is the respiratory rate of the patient. तो इस तरह से ग्राफ जो है आपके मल्टीपैरा मॉनिटर पे दिखाई देगा. नेक्स्ट. We can attach this EtCO2 sensor either directly to the ET tube. आप directly ET tube से उसे connect कर दीजिए. This is called as a mainstream capnography. या उसे adapter के through sensor के साथ attach कर सकते हैं. This is side stream capnography. So there are two methods by which we can connect EtCO2 sensor. Next. This is capnogram. Capnogram मतलब एक थोड़ा सा एक बेसिक आइडिया होना चाहिए कि इसमें ये है, क्योंकि बहुत सारे वैल्यू जस्ट ये मॉनिटर पे आ रहा होता है ग्राफ. आप बहुत सारी चीज डायग्नोज कर सकते हो, बहुत सारी चीजें आप अर्ली देख सकते हो पेशेंट में जस्ट बाय लुकिंग एट द ग्राफ ऑफ दिस पेशेंट. तो ये है, if it is visible to all of you, there are two colors, white color and the yellow color. White color is inspiration part and yellow color is the expiration part. This is starting of this graph. We have end of inspiration जहाँ पे yellow start हो रहा है, and this is start of expiration. Start of expiration is phase 0 of this graph. Phase 0 there is starting of expiration and there is clearing of dead space. Dead space clear हो रही है तो इसकी वजह से कोई CO2 नहीं produce होता, तो इसलिए flat है यहाँ पे graph. फिर क्या होगा? This is phase 2 of this graph. There is a rapid rise in CO2 as the air from the alveoli containing the CO2 reaches the upper airway. जितनी अंदर की CO2 है सारी ऊपर upper airway में आ गई, तो there is a rapid rise in the EtCO2 value. CO2 value. This is CO2. So this rapid rise is there is rise in CO2. उसके बाद है phase 3. That is called as a alveolar plateau. This here the CO2 reaches the uniform level. And this height of this plateau is related to the cardiac output of the patient. तो एक cardiac output का भी assessment ले सकते हैं हम just by looking at the height of this plateau. Then this circle जो blue color का circle है, this is the end point of the expiration. Hence the reading which is taken by the sensor is the end tidal CO2. तो ये वाली रीडिंग ही है जो सेंसर लेता है, जो आपके मॉनिटर पे दिखती है, दैट इज एंड टाइडल CO2. यहाँ पे आपका एक्सपिरेशन खत्म हो गया, फिर देन देयर इज अ स्टार्ट ऑफ एक्सपिरेशन. ये वाइट पार्ट इज स्टार्ट ऑफ इंस्पिरेशन. तो एट द स्टार्टिंग ऑफ इंस्पिरेशन देयर इज अ रैपिड डिक्रीज इन द CO2. तो हियर इट इज decreasing value of CO2 is cleared from this, and then again the inspiration begins and CO2 is cleared. So this is the normal capnogram. Next. अभी जो ग्राफ देखा, अब उससे हम देयर इज दिस क्लिनिकली हम कैसे असेस करेंगे. फर्स्ट वी विल ऑब्जर्व द फर्स्ट ग्राफ. इसमें क्या है, पहला वाला नॉर्मल कैप्नोग्राम, सेकंड देयर इज अगेन अ नॉर्मल कैप्नोग्राम, and there is a loss of waveform, एकदम से गायब हो गया, चला गया, CO2 ही नहीं आ रहा बॉडी से, तो इसका क्या इंफरेंस है? दैट इज ET ट्यूब इज डिस्कनेक्टेड, आइदर इट इज डिसलॉज्ड, किंक्ड और ऑब्स्ट्रक्टेड, और या एम्पलीट्यूड नहीं आ रहा है बिल्कुल भी, तो दैट इज लॉस ऑफ सर्कुलेटरी फंक्शन. दिस इज नॉर्मल. दिस इज फर्स्ट वन. नाउ वी विल लुक एट द सेकंड वन. सेकंड वन में क्या है? एक नॉर्मल कैप्नोग्राम आया, फिर डिक्रीज हो रहा है और डिक्रीज हो रहा है और डिक्रीज हो रहा है, फाइनली ये डिक्रीज होता चला जा रहा है. तो उसका मतलब है CO2 आ रही है बॉडी से, पर कम आ रही है. क्यों आ रही है? या तो वो ET ट्यूब कहीं का लीक कर रहा है, या गलत जगह पे पड़ा है, हाइपोफैरिंक्स में पड़ा है, या पार्शियल ऑब्स्ट्रक्शन है, तो पूरी CO2 ही नहीं आ पा रही है आपकी. थर्ड वन इज फॉर द असेसमेंट ऑफ द CPR. अगर एटलीस्ट 10 का एम्पलीट्यूड आ रहा है आपके उसमें, तो that means it is showing this we are doing a good CPR. Then there is a sudden, ये normal capnogram, normal camera, and then there is a sudden increase. What it shows a return of spontaneous circulation. Then there is this bronchospasm, shark fin appearance, typically seen in asthma and COPD patient. Then there is decrease in frequency which depicts hypoventilation. Then there is increase in frequency which depicts hyperventilation. इसमें क्या है? लास्ट वाला जो सबसे वाला देख रहे हैं, इसमें नॉर्मल कैप्नोग्राम थोड़ा डिक्रीज और ये बिल्कुल फ्लैट वाली हो गया. तो either there is apnea or there is patient is deeply sedated. तो वो CO2 वाला जो रिस्पॉन्स है वो नहीं आया है इस पेशेंट में. तो जस्ट बाय लुकिंग एट द ग्राफ वी कैन डायग्नोज सो मेनी थिंग्स. तो एक बेसिक आइडिया से भी आप बहुत सारी चीजें आप पता लगा सकते हैं जस्ट बाय लुकिंग एट द कैप्नोग्राम वैल्यू इन द मल्टी पैरामीटर. नेक्स्ट. Next important component of using any multi-para monitors are using alarms. We have audio alarms. ऑडियो आता है, तरह तरह के कई साउंड्स प्रोड्यूस करता है. विजुअल होती है, पहले ग्रीन लाइट आएगी, फिर येलो लाइट आएगी, फिर आपका रेड लाइट आएगी. वी शुड नो, मतलब अगर अलार्म बज रहा है तो वी शुड रिस्पॉन्ड टू द अलार्म. अननेसेसरी नॉइज पॉल्यूशन भी नहीं होना चाहिए उसमें आपके ICU सेटअप्स में, और आपको अलार्म्स यूज करने में, मतलब वी शुड बैलेंस इट. First of all, set the alarms rate according to the heart rate, respiratory rate, BP, saturation, temperature. और arrhythmia के भी आप alarm set कर सकते हो अपने multi-para monitor. And alarm should be cautiously used. Next. Maintenance, using मतलब one of the important aspect of using any machine is the maintenance of this machine. क्योंकि हर मशीन स्पेशली गवर्नमेंट सेटअप में लाने के लिए बहुत मेहनत करनी पड़ती है, और फिर उसका मेंटेनेंस उतना ही इंपॉर्टेंट हो जाता है. तो वी शुड यूज इट very carefully. Extension cable should be tucked in a bag when not in use. Disposable accessories, we should use disposable accessory as much as possible. Reusable accessories to be cleaned with speed swab and in between. And accessories when not in use should be kept in a label box. Especially जो important part होता है ना, sensor ही सबसे पहले खराब होता है और वही सबसे ज्यादा यूज होता है. उसी में वियर एंड टियर वाली प्रॉब्लम्स आती हैं. तो सेंसर व्हेन नॉट इन यूज शुड बी प्लेस्ड इन एयर टाइट कंटेनर. हमारा जो सेंसर है वो इधर उधर पड़ा रहता है जब भी है, पर उसे एक हैबिट हमें डेवलप करनी चाहिए कि जब यूज नहीं हो रहा है हमारा सेंसर तो उसे आइडियली एक एयर टाइट कंटेनर में रख देना चाहिए. तो दिस प्रोलॉन्ग्स द लाइफ ऑफ आवर सेंसर. नेक्स्ट. So what are the key messages? Real-time monitoring of all parameters is very important. We should use sensor properly, and we should know what are the age-appropriate limits of heart rate, respiratory rate, and we should set alarms accordingly. Early warning of adverse changes or trends should be taken. Response to therapeutic intervention should also be monitored, and we should reflect proper functioning of other equipment too. Next. If one want in-depth knowledge, we can go through the following references. Next. Skills to be learned, understand various parameters. ये तो कुछ parameters थे जो हमने within 30 minutes में describe करे. तो there are other parameters which we can use in monitoring of the patient. Identify compatible and appropriate sensors, identify and interpret abnormalities, and set alarm limits. Next. This is my last slide and my favorite one. The most important monitor is clinician. Next. We should remain vigilant and integrate our information accordingly. सबसे important होता है कि just don't follow numbers कि ना saturation इतना हो गया, heart rate इतना हो गया, numbers की तरफ blindly follow नहीं करना है. We should always use our clinical sense. कई बार क्या होता है कि ये बच्चे पे सेंसर नहीं, वो दूसरे पे लगा हुआ है, उस पे मॉनिटर कुछ और रीडिंग आ रही है, पर अगर आपका क्लिनिकल सेंस कह रहा है कि नहीं बच्चे में कुछ प्रॉब्लम है, तो ऑलवेज असेस द पेशेंट. Don't go by numbers blindly. That is very important. We should use clinical sense always. That's all. Sincere thanks to all the contributors. My sincere thanks to Dr. Chandrakanta ma'am and Dr. Shelly Avasti ma'am. Thank you, ma'am. Ma'am, there are 3 videos which I want to show. The 3 videos will be showing you normal ECG placement, ECG placement and ETCO, how to take ETCO2 and this BP one. Neeraj, please show the 3 videos.
ECG cable has also 2 part. One is the connecting cable and second part that is connected to the cable and the ECG leads that have to directly attach to the baby. Usually we go for the 3 lead ECG with the left part, right part and the lower limb component that has to be attached. We can also attach to the lower left abdomen of the baby. Leads has to be attached to the baby with the electronic pads. After connecting the lead to the baby and to the monitor, there is a direct display of the ECG on the display monitor and we can directly assess the pattern of the ECG of the baby, involving the assessment of the any electrolyte imbalance or a arrhythmia. ECG leads also give a heart rate of the baby, and in the setup we can select lower limit or upper limit of the heart rate according to the age of the baby and directly involvement and assessment of baby. Thank you. For the end tidal CO2 monitoring, we have a separate micro stream sampling line that take the sample from the exhaled air and send it to the sensor that present in the separate module. In this version 19, we have a separate module that put into the satellite unit and the sensor is present in this module. After inserting this module into the satellite unit, we have to plug in the microstream sampling line with one end to the module and other end connected to the baby, depending upon the baby on the invasive or non-invasive mode of ventilation. For the invasive mode of ventilation, we have a hub with connector to the ET and other end to the ventilator circuit. For the non-invasive mode of ventilation, we have a nasal cannula microstream sampling line that can be used for the baby. After connecting the sampling line, ETCO2 number will display on the monitor and then we can regulate the baby's ventilation status by assessing the end tidal CO2 more frequently with the non-invasively, and ultimately that will increase the frequency of ABG and decrease the sampling of the baby. For the blood pressure monitoring of patient, we have this non-invasive blood pressure monitoring NIBP cable with the one end attached to the module and the second end will attach to the disposable BP cuff. And BP cuff is available in the different size depending on the baby's age and the weight. After connecting the cable and cuff to the baby, we will start measuring of blood pressure by pressing the knob or the touching the screen. That option is available in the monitor. And frequency of measurement of blood pressure is can be manually or it can be set in the according to the requirement, from varying from 5 minutes to every 2 hours, that automatically the monitor will assess the blood pressure. While the measurement of the blood pressure, the reading will be there, and ultimately at the end, the blood pressure with systolic, diastolic, and mean will appear on the monitor. In this baby, the blood pressure is the higher range, so alarm is blinking. For the alarm setter, we touch the parameter and the separate window will pop up, and according to the gestation of and age of the patient, we can decide the low and high for each systolic, diastolic, and mean blood pressure. This is a Mindray Benevision N19 multipara monitor with the display unit and the satellite module unit. This satellite module unit have the different slot for the modules, and this is comprehensive module that includes the ports for the NIBP cable, temperature cable, invasive blood pressure monitoring cable, ECG cable, and the SpO2 cable. So this comprehensive module we can assess around 5 to 6 parameters maybe with this comprehensive module, except ETCO2 that we have a separate module that we have to attach. So in the SpO2 monitoring, after attaching the SpO2 cable one end to the module and the sensor part to the baby, mostly with the preductal or postductal depending upon the situation, in this baby in the left lower limb. So after attaching the sensor to the baby, the SpO2 monitor, SpO2 level will display on the display unit of multipara monitor, and along with the SpO2 assessment, with this technology we also assess the heart rate and pulsatility index of the baby. Pulsatility index depending upon the pulse volume and the volume status of the patient, that is displaying on the monitor. This bar is showing the signal strength of the signal, and this is regular and in the adequate amount, so it's showing that it's a good signal, and the value is accurate, and we can rely on this SpO2 value. For the alarm settings, after touching the parameter, the pop-up second bar will pop up, and depending upon the age and gestation and requirement of the oxygen, depending upon ventilator status or oxygen support, we can set.
Ma'am, that's all from my side.
Thank you, Dr. Anupma, for explaining everything so nicely.
Thank you, ma'am. Thank you.
I don't see any question for you. So thank
Okay,
you.
ma'am. Thank you, ma'am. Thank you.
Thank you. And for next talk, I invite Colonel Dr. R.K. Thapar, sir. Sir is retired from the army and presently working at Sharda Hospital, Noida. And he will be talking about the indications and modes of mechanical ventilation. Over to you, sir.
Thank you, madam. Thank you, Dr. Kanta. I thank all the panelists and all my participants who have spared their holiday and attended. They're attending with us. So I'll start with the presentation. That is the indication and modes of ventilation. My only thing is that for last 2 days, you have been told about the COVID problem, the mild COVID cases, the moderate COVID cases, then the assessment of sickness of the child, and then the sporting the child, like that how you have to sport the oxygen therapy, the various modes of non-invasive modes of ventilation. So we will be happy that if we get away with the such type of so far so good, whatever you have learned, probably if that can be put into use, and then probably we may not require going for the invasive ventilation. But things may go wrong also, because the mild moderate cases may we will be able to manage by non-invasive ventilation. However, severe cases may require invasive ventilation. So my previous two panelists, they have already sensitized you towards the various terminologies and the monitoring part. So now I'll take you further for the indications and modes of ventilation. My only request is that in a 30 or 40 minutes time before lunch, we'll just be touching upon the basic things. We'll not be going into the various hybrid modes of ventilation. Probably the person who is interested, he can go ahead, and somehow this refreshing training is just as a part of refreshing. You must already be using your equipment, and you must be doing ventilation already. So it will be just a refreshing of your knowledge, and maybe sensitizing to the prevailing situation which we may encounter. So my learning objective will be that we'll be discussing ventilation, invasive causes of respiratory failure. Briefly, we should know what are the causes and what is COVID is causing the problem, why it is causing the respiratory failure, and we'll try to understand the different modes, basic modes, and which you may be using already, and how to choose the appropriate mode. So my learning objectives are very, very crisp. So as all of you know, that normal respiration is nothing but intake of oxygen and elimination of carbon dioxide. It is as simple as that. So when normal things don't work, that means when the lungs don't do their job, what will happen? There will be a failure of oxygenation and there will be failure of carbon dioxide elimination. So these are the two jobs which the lungs are supposed to do. And so our aim is to support the child till the time is spontaneous recovery happens. Now, if we grossly go into the causes of respiratory failure, so the respiratory failure can be central cause. Respiratory center may be involved in injuries or some poisoning. Then from the brain, the message comes to a spinal cord. It may get involved. So we may have the problem associated with the spinal cord. Then all of us as pediatricians, we are very comfortable. We know about the GP syndrome and the various neuropathies. That means the involvement of the peripheral nerve leading to respiratory failure, and then myasthenia, various toxins which act on the neuromuscular function. Muscles may be involved in myopathy, airways, asthma. We see less of nowadays, but still acute flare-ups in asthma. This is what is the COVID or pneumonia, ARDS. So they will be involved in the alveoli. So this is how we are going to deal with the cause of respiratory failure within the alveoli as far as pneumonia or COVID is concerned. For the ARDS part, you will be taken to tomorrow.
Hello.
Yeah.
Sir, your voice is not coming.
Okay, it's not coming at all.
Yeah, now it's audible.
Okay. So I was discussing about the various causes of respiratory failure. In case of pneumonia, it is the alveoli, the COVID pneumonia. Alveoli are involved, and for ARDS, you will be given a talk tomorrow. And lastly, the cavity itself may be involved. That may be in the form of pneumothorax or pleural effusion. So these are the basic causes of respiratory failure. Now, then, before we go for invasive ventilation, we have to have a quick assessment that around the diagnosis of respiratory failure. Clinically, the child will be having tachypnea, difficulty in breathing, will be seeing the use of accessory muscles, retractions. There may be cyanosis, the SpO2 may be low. The child initially may have tachy or hypertension, but subsequently, when the fatigue sets in, then the child goes into bradycardia along with hypotension, and clinically we may hear some adventitious sounds in the chest auscultation. And these are the findings which will be collaborated by the few investigations. For example, a low SpO2 if we start monitoring as previously told, and then if we do a blood gas, the simple premise is that if PO2 is less than 60 and PCO2 is more than 50, so that will identify that the child is in respiratory failure. And maybe we can further collaborate it with the X-ray chest or maybe CT scan in case it is desired. But most of the time, X-ray chest will be able to help us in deciding the situation. So these are the things which we already have been told to, and all of these things will tell us that the child is having increased work of breathing, which we have to relieve. So that means how we'll relieve that work of breathing. For example, if there's only hypoxia, as has been told to you earlier in the yesterday's talk, then probably we can give oxygen therapy, which can be in the form of nasal prongs, mask, rebreathing mask, or HFN. So that problem can be, we can sort out the target saturation and we can help the child tide over the crisis. Whereas in case there is hypoxia along with hypercarbia, but the child still has good respiratory efforts. So in that situation, probably our NIV, that CPAP, BiPAP, which must have been told to you yesterday, may help us. So we are trying, we are going step by step, that only in the severest of cases where there is a severe hypoxia, severe hypercarbia, and now the child is tired, the efforts are less, the child is going into apneic sort of thing, and if he is showing respiratory failure, so this is the time we have to go for invasive ventilation. So our choice of patient has to be very, very clearly demarcated. Now, having decided that now is the time we will not be able to maintain the saturation, maintain the child's condition with the oxygen therapy alone or with a non-invasive mode of ventilation. So we'll go ahead with the mechanical. What will be our goals? Our goals are only two basic goals. That there's the problem of oxygenation, so we try to maintain oxygenation. There's a problem of carbon dioxide elimination. We'll try to improve that. So basic goals of mechanical ventilation remains oxygenation and ventilation. Now, as has been told to you by Dr. Manisha, that oxygenation is determined by MAP and FiO2. MAP is further dependent upon your PIP, PEEP, TI, and TE. So those are the parameters which will determine the MAP. Of course, FiO2 is another constituent of oxygenation, whereas ventilation, that is carbon dioxide elimination, is dependent on the minute ventilation, which is the product of respiratory rate and tidal volume. So these are the few parameters which we can play. Now coming to the modes of ventilation. So there are basic modes of ventilation, maybe in the form of controlled mandatory ventilation. We'll see to that how it works. That means everything is controlled by the ventilator. Assist control, we are giving some autonomy to the patient. That is, we are assisting the patient. The patient has got some efforts. We are assisting plus controlled ventilation. So it is a mix of assist control. Then the mode which we all are very familiar with is SIMV, that is synchronized intermittent mandatory ventilation. It gives further autonomy to the patient. It is a form of patient-triggered ventilation. Then on the top of it, we try to support the patient's breath. Not fully, but the patient takes a breath and we support it. That becomes pressure support ventilation, which may be add on to the SIMV. Then primarily, Dr. Manisha has also mentioned that we can choose one of these two, either pressure control or volume control. Both have got their own plus and minus points, and it is your ease of using the mode which will decide, we should decide. Both have got their own pitfalls. And in neonates, we are very comfortable. We have been using so far pressure control ventilation, but studies are coming up which say that even volume control ventilation is also good. And there may be certain types of hybrid modes where it is pressure regulated volume control. So now the machines are coming in which you will be able to control both the parameters. So that is a little hybrid modes on a very advanced ventilators, which they are coming up now. So let's stick to the basic things first. So this is how a ventilator will be. There will be a blender which will be in the machine. Basically, we have got oxygen source and air source. And this is from the blender that we control the FiO2. There's a knob. So when we press 50%, so 50% of each of these comes. Similarly, if we increase oxygen, so air entry will be less and oxygen entry will be more. So this is the function of blender. Then we have got the various valves, inspiratory valve, flow transducers, and similarly pressure transducers and the expiratory valve. So these are the valves which control our PIP, our PEEP, and the flow and the various timings. So this is the nutshell anatomy of a ventilator, and from where we get the connections tubes to the lungs. So this is in a nutshell about the ventilator. Now comes controlled mandatory ventilation. Now, what happens in controlled mandatory ventilation is that everything is controlled by the ventilator. That means patient has got no say. So that means either the patient is so sick that patient doesn't have his own efforts. So everything is controlled by the ventilator. We set the things and ventilator delivers that. Or if the patient has got the effort, then probably we have to sedate the patient. We have to paralyze the patient so that only mechanical breaths are being delivered. So in a nutshell, all the parameters are controlled by the ventilator. Patient cannot trigger the ventilator. So there is no autonomy to the patient. So what are the disadvantages then? Probably then it can only be used in apneic patients. There may be asynchrony if the patient has spontaneously breathing. Now the patient has started improving with your therapy, with your treatment. Now patient is making some effort, but machine doesn't have those efforts. Machine doesn't have those efforts. So machine is giving his own breath. Child is having his own breath. So there is a asynchrony which is not desired. Synchronization in a ventilation is a must. So otherwise, we have to use a heavy sedation and muscle paralysis and pay a price for that. Now, what comes next is assisted controlled ventilation. So what happens here? Now, here, the patient takes a breath. There's a negative pressure generator. So it's a trigger. Earlier, the machine was totally controlling the things. Now, patient has taken a breath, and then what happens is that the ventilator assists that breath. That is how it is an assist control. So patient can trigger, and once triggered, the most of the parameters will be controlled by the ventilator. But at least there is some synchronization that ventilator is recognizing the patient's effort and is helping, supporting those efforts. There will be less of asynchrony. But again, there will be expiratory asynchrony. There may be less of inspiratory asynchrony, but still, when the patient is in the expiration phase and the ventilation is in the expiration phase by the ventilator, and if the patient takes a breath, so there is a chance of expiratory asynchrony in the assist control ventilation also, but certainly better than CMV. So problem is that there may be a problem of hyperventilation, because if you set the trigger very, very sensitive, that small effort by the patient is picked by the ventilator. So ventilator supports that breath. So in case every effort, small effort is also, so there is a possibility of hyperventilation. And asynchrony between and now you have set certain rates. So those rates, the ventilator will pick up those breaths and will support those breaths. So there is a possibility of asynchrony still persisting here, though some amount of it will be taken care of. Now, next, see what happens with the SIMV. Now, in the SIMV, what we see is that we give fixed number of breaths are assisted by the ventilator. So patient triggers the breath, the ventilator delivers the breath. In between, the ventilator will not detect, will not give any assisted breath. So there will be certain breaths with whatever the rate we have set, 18, 20, 22, depending on the age and the condition of the child. So during the mandatory breaths, these are the two mandatory breaths, the patient can breathe spontaneously. So it's a better than the assist control also. Patient is free to breathe during expiratory pause. That's the beauty. So there's a less of asynchrony. So what can the advantages of SIMV? The patient can breathe spontaneously between the mechanical breaths, which you have already set. The ventilator will not disturb the baby in between. and the ventilator support is tailored to the patient's demand depending on the condition. And basically, if you keep on trying to reduce the mechanical breaths, you are giving a chance to the patient to breathe. So basically, it's a sort of a weaning mode. That is, it facilitates the weaning by gradual reduction of mandatory breaths. There's a reduced need for sedation. Naturally, now you are trying to allow the patient to take breaths. So naturally, we have to cut down on the sedation and paralysis. So not only that, it preserves the spontaneous respiratory efforts. Otherwise, if we keep on ventilating the patient with so much of sedation and paralysis, the respiratory muscles may go into atrophy. The extubation may become a problem. But it has got some of these disadvantages, like increased work of breathing during spontaneous breathing due to expiratory. So there is some element of expiratory asymptomy in SIMV mode also. Now, let's see what happens in the pressure support ventilation. Now, the inspiratory pressure support, which is applied to the spontaneous breath to eliminate. Now, these are the spontaneous breaths. These are not supported. In pressure support, what happens is that we try to support these breaths also, because the patient may be able to generate 6, 7, 8 centimeters of water pressure. And if we support them with another of 8 to 10, so that it reaches the PIP levels. So this is what is pressure support ventilation is that. Basically, it is developed to relieve the work of breathing in the spontaneous breaths. जो mandatory breaths के बीच में आए, उसके दौरान भी उसको भी जो work of breathing है, उसको relieve करने के लिए we can give the pressure support ventilation, but it may be used as an independent mode when the patient has got their own efforts. So patient here initiates the breath. Patient's effort has to exceed the trigger sensitivity. Now, trigger sensitivity has been told to you by Dr. Manisha that it can be timed, which is the ventilator, then pressure and volume. So there is a button in the ventilator where you can choose. Either you choose the pressure triggering or flow, that is a volume triggering. So not much of it their choice, but -1, -2, -3. So depending upon how much you want the patient to generate the negative pressure, so that the ventilator detects that now, if we set a very high sensitivity, then probably it will pick up all. It will support all. Now, if we gradually start decreasing the sensitivity, so once the patient generates 4 or 5 centimeters of negative pressure, then the ventilator picks up. So that is how we decide the trigger sensitivity, and we try to give the inspiratory flow to attain the pressure level which we have set, that we will be giving 10 centimeters pressure support. So it will be more than the PEEP, that 10 centimeters will be more than the PEEP. That will be our level, pressure support level. And the inspiratory flow will continue to maintain the target PS level as long as the patient's spontaneous effort continues. So this is the beauty of pressure support ventilation, that it is more patient friendly. So the pressure support ventilation will look like that. This is how the curves will look like, that there will be trigger sensitivity in the pressure, and this is how the volume will move like this. So beauty of this pressure support ventilation is that all breaths are initiated by the patient. If we are using it as a standalone, once initiated, the ventilator supports the inspiration जो आपने level set कर दिया है, उसको भी whatever level you have set at 14, 20, whatever level you have set, that much pressure it will be given to the spontaneous breath, and pressure support only as long as the patient is in the inspiratory phase. That's another good thing, that there's less of asymptomy now. So patient will remain in a synchronized with the ventilator. So these are the advantages of pressure support ventilation. But little bit you have to do, that you have to set the trigger, you have to give a pressure support level, and maybe some pressure support slope, which Dr. Manisha mentioned about in the map. Once they say you can set the slope and probably expected trigger, and the rest of the parameters we all set in the PEEP, FiO2 and alarm as we set in the other. So trigger is the one which we have to set, and the pressure support level. So these are the two additional factors which we have to set in the pressure support ventilation. So advantages are great, that it preserves patient spontaneous efforts, and patient has a control on all phases of respiratory cycle. So it's one of the best modes of patient triggered ventilation, PTV. and it reduces the work of breathing in proportion to the level of PS. Of course, whatever level you have decided, depending on the age of the child and the disease condition, yes, with this much pressure support, the lung chest rise is adequate and there is oxygenation. But it do have its certain disadvantages, like it can be only used in a spontaneously breathing patient, just like your non-invasive ventilation. CPAP, BiPAP has to be used when the patient has got a spontaneous breathing effort. But the tidal volume and the minute ventilation will vary. Now you, as has been told to you earlier, that lung mechanics, the resistance, the compliance of and the patient's effort, these things will determine the exact tidal volume and the minute ventilation, which may be variable, because in the acute phase there is a lot of resistance, lot of poor compliance. So the tidal volume and the minute ventilation may not be appropriate. But as soon as the condition improves, the compliance improves, the resistance decreases, then the tidal volume, you will be able to achieve a better tidal volume and the minute ventilation. So that thing is the only disadvantage, you can say, that it gives you variable tidal volume and minute ventilation. So next is the which mode you will like to use. Again, it is your choice, your comfort, your ease, and the machine you are working with. That should be the criteria. Both have got their own pros and cons. Whether you use a pressure controlled or a volume controlled. In a pressure controlled ventilation, you set a pressure, as simple as that, and tidal volume will be variable, as I alluded to earlier, that it will be determined by the lung mechanics. So advantage is that since we know that too much of pressure will be barotraumatic, so we will set the pressures below that level. Then definitely there will be recruitment with the mean airway pressure. When we have got a increased mean airway pressure, so the alveoli which remain collapsed with the increased PEEP, these alveoli will be recruited. So that is the advantage of pressure control ventilation. But if you see the disadvantages, that is just because of the lung condition, that the variable tidal volume. And if we keep too high a mean pressure, we all know that even if whenever we are using CPAP, I see CPAP or PEEP, so if we have a more mean airway pressure, definitely the venous return will be less and output will be impaired. So keep those things in mind. It's not all or none law, but we have to keep following the patient as a clinician. So this is how a volume control will look like, that you have controlled volume. It will remain unchanged irrespective of the lung compliance. Now you have set the tidal volume at 8 ml per kg. So you have set about maybe 25 kg, you have set about 200 ml. So it will keep on delivering 200 ml. The ventilator will deliver the pressure to achieve the tidal volume. The pressure will vary. Now in the pressure control, the volume varies. In the volume control, when we set the volume, naturally it all depends on the condition of the patient. The pressure varies with breaths. So this is the point to be noted, that we have to keep in mind these two things. So advantage is that since we are giving adequate tidal volume, so there's a chance of reduced work of breathing. Then it allows the patient to increase the minute ventilation, but you can't decrease. You already set कर दिया है उसको, तो उतना तो मिलेगा ही मिलेगा patient को. Patient can have increased ventilation, but at least minimum is ensured. Similarly, disadvantage is that it can have adverse hemodynamic effects or inappropriate hyperventilation. There's a problem of hyperventilation. Then airway pressures, as I already told you, which will vary with the lung compliance. And in case there is a high flow demand from the patient, which will not be met by the fixed flow, because we have already set fixed volume, because we will give tidal volume of 200 ml. So in case the patient demand increases, probably that's the disadvantages of volume control. So both of mode have got their own issues. So we should decide upon our comfort and ease. So these are the various pulmonary graphics which will be depicted in a volume cycle. The airway pressure will rise gradually. The alveolar pressure, that is the pressure which is delivered to the alveoli. And whereas in the pressure cycle, this volume fixed, this is the pressure fixed. Here the alveolar pressure will be a gentle slope. and flow will be, initially there will be high flow, and then gradually once the flow declines in the inspiratory phase, and then the expiratory phase. So these are the things that once, whatever mode you set in, you just see the pulmonary graphics accordingly. So my key message will be that synchronized and patient-triggered ventilations are preferred. So let's give some autonomy to the patient, provided patient has got spontaneous efforts. Of course, sick children, very severe cases in which we don't want to fatigue the patient more, maybe we can assist control mode will be a better choice. But in mild to moderate sphere of illness, in that situation, maybe when the patient is having their own spontaneous efforts, then our SAMV will be a good modality to use, along with pressure support maybe. Then choose a mode which I am already telling you again and again, in which you are more confident. And not only that, there are a lot of variables which you set in the ventilator, and there are a lot of variables which you will see in the ventilator once you turn off the knobs. That is the delivered parameters. Some of the ventilators, they tell you about the tidal volumes, expiratory tidal volume, compliance, dynamic compliance. So there are various things. If you go into the parameters monitoring, then you will see that so many things are there which is being calculated, so that you can at least see that my compliance, how the resistance is improving, how the compliance is improving. That can be seen from the pulmonary graphics also, as well as numerical variables. You just get friendly with your machine, whichever machine you are having. Set alarms naturally. Eye on various alarms, that there may be a oxygen failure alarm, there may be a sensor probe, oxygen sensor alarm, so and flow alarm. There are various alarms that we must give some attention to those, because initially they give you a little warning, maybe amber color. Then subsequently some of the alarms may be red color, which you can't just ignore. You have to attend to those alarms. So get familiar with those issues also. And a lot of things, a lot of material reports, regulation, people can have access to very rich material on ventilation, so that you can keep on updating your skills and knowledge. Basically, that you should try to understand the different types of the mode depending on the clinical condition. Sick child, probably you will use a controlled mandatory ventilation for a short time. Then setting the parameters. Detailed setting of parameters will be told to you in the next class after the lunch, so that depending on the condition, that patient is in ARDS or which condition, how much pressure you have to set, then please have a look on the displayed parameters. That will be a good idea. Spend some time with the machine and monitor the patient and ventilator synchronization. That's very important, because asynchrony will be good, and patient will have a lot of arrangement because of asynchrony. Try to have a patient ventilator synchronization, maybe use of little bit of sedatives in case required. Thanks to various contributors who have made up this whole program for the healthcare providers. And here I stop sharing my, I have finished well in time for your lunch. Any questions, I'll be happy to answer.
Thank you, sir, for your excellent presentation. And I don't see any question in question answer box. So thanks for joining us. And I think the participants must be feeling hungry till now. So we are taking a lunch break for 20 minutes. And after 20 minutes, we will start again. And we have three more important sessions today: the endotracheal intubation, the initial settings of ventilation, and the weaning and extubation of the child. So all of you, please join sharp after 20 minutes. So we break for a lunch. So welcome back again. And for the next talk, I invite Dr. Kavita Meena. Dr. Kavita Meena is Associate Professor at IMS BHU Varanasi, and she will be talking about the endotracheal intubation and airway management. So over to you, Dr. Kavita. Hello.
हेलो
Am I audible, Dr. Kavita?
हाँ जी मैम बिल्कुल
Okay. So please start.
मैम कैन यू गिव मी 5 minutes just 5 minutes
Hello?
am I visible ma'am hello
Yes, ma'am, you are audible.
okay Good afternoon, everyone. Today we'll be discussing about endotracheal intubation in children. And our learning objectives will be understanding the key anatomical differences between pediatric and adult airway, comprehension of the equipments and preparation required for endotracheal intubation in children, procedural step for performing endotracheal intubation. Overview, we'll complete the lecture in the form of indications, contraindications, anatomy, preparations, procedural steps, aftercare, potential complications, and common pitfalls. Now, for the indication of endotracheal intubation, there can be failure of oxygenation or ventilation. Like if we measure the PaO2 of the patient, it comes around less than 60 millimeters of mercury on 60% FiO2, or if the partial pressure of carbon dioxide is more than 50 millimeters of mercury, or patient has inability to maintain or protect his or her airway, or there is a systemic conditions like hypotensive shock, or patient has undergone cardiopulmonary resuscitation, or patient is undergoing anesthesia, procedures requiring sedations, or neuromuscular disorders. Now, in case of contraindications, there are no absolute contraindications for endotracheal intubation, but there are few relative contraindications, which are anticipated difficult airway, difficult to intubate, alternative airway, or expert team. If we talk about the anatomy, there is a basic difference in the adult and the pediatric airway. In case of adult patient, the shape of the airway is cylindrical, whereas in case of pediatric, it is funnel shaped. Tongue is very large in case of pediatric patients, so it is bulky, it is easily collapsible. And if we talk about the narrowest part, in case of adult, it is the vocal cord, whereas in case of pediatric patients, it is the cricoid ring, which is the narrowest part. And in case of pediatric airway, larynx is more anteriorly placed. That makes it very difficult to intubate a pediatric patient compared to the adult patient. So what do we need to do? We need to align the airway before attempting for endotracheal intubation. Why we need to align the airway? Because there is a relatively larger head in infants. So the neck is naturally flexed, which compresses the soft tissue. Tongue is relatively large, and tongue keeps falling back, which leads to airway obstruction. So how do we do the airway alignment? We need sniffing position for intubation and laryngoscopy and intubation. So we have three endpoints, which we should always check these endpoints. First, if we compare the glabella and chin, the plane, it should come into this straight line, and this plane should be parallel to the ground. Or if we see, there should be wide and open. This neck area should be wide and open. And if we see the external auditory meatus and sternal notch of the patient, it should again should be into a straight line parallel to the ground. So how do we achieve this position? First of all, keep a patient on flat surface and you check these endpoints. If these endpoints are met, then it is fine. But if it is not, then we should try placing a headrest, and then again we should check the endpoints. And if we are able to not achieve the endpoints, then again we should try placing a shoulder roll below the shoulder of the patient, and we should again check these endpoints. If these endpoints are met, it means your patient is in position, and we can attempt for laryngoscopy and intubation of the patient. So this picture again showing the differences in the endpoints that we need and the differences in the endpoint that are shown here. So this should be checked, and after achieving sniffing position, then only we should attempt for laryngoscopy and intubation. This picture again showing, this is the ear to sternal notch. So we should check the ear and sternal notch of the patient. And this is the line which is passing through the anterior part of the shoulder. So this line should be parallel to the ground. So in case of infant, in case of small child, and in case of older child or adult, we should see this line, whether it is parallel to the ground or not. Or if not, then in case of infant, we can place a shoulder roll and check this position, this line. In case of small child, we can just keep the child on the flat surface, slightly extension of the head. And in case of older children, we can put a support behind the head of the child. So we should always check before attempting for laryngoscopy. So once we have placed the child and we have attained the desired position, we should know what we are aiming for. So we should know the anatomical landmarks that we are looking for after doing the laryngoscopy. So these are the anatomical landmarks. This is the vallecula. These are the vocal cords. These are the arytenoid cartilage. This is the epiglottis. These are array epiglottic fold, and this is the glottic opening. So when we should try and identifying the epiglottis of the patient, then we should try and identifying the vocal cords of the patient. Vocal cords are glistening white structure lining the glottic opening. So we should be able to identify the vocal cord, and this vocal cord lines the glottic opening. This is again the anatomical landmark. So this is the airway opening of the patient, and this is the esophagus. So we should able to identify, because airway is always lined by the epiglottis, and we should not intubate, or we should not make any mistakes, and we should able to identify. So the shape of the epiglottis, as a patient grows, the shape of epiglottis changes. In case of newborn, it is inverted U shape. In case of child, it is triangular. And in case of adult, it is semicircular in shape. So we have achieved the position. We have seen what to be. We have seen what we need to see after doing the laryngoscopy. But before attempting for laryngoscopy, there are certain other preparations, and these preparations can be remembered by a mnemonic, which is SOAP me. So we need suction apparatus, which can be wall mounted or which can be standalone. Suction pressure should be around 80 to 100 millimeters of mercury. Then we need suction tube, and then we need suction catheters. Size should be 8 to 14. Then we need to give oxygen to the patient. So we can provide by non-rebreather mask or nasal cannulas. We need ambu bag with a reservoir, or we need oxygen tubing. For the airway, we need appropriate size of endotracheal tubes, oral and nasal airways, and laryngeal mask airway. Then personal protective equipment should also be available. Then we need medications like pre-medications, paralytics, resuscitative medications like epinephrine, atropine fluids, etc. Then we need equipments like laryngoscope, appropriate size blade, mask appropriate size, ambu bags, stillets, IV lines, syringes, tape, towels or pads for airway alignment, stethoscope, monitor, end-tidal CO2 or calorimetric capnograph. And after intubating, we should keep the ventilator ready for the patient. In case of laryngoscopes, there is a basic difference whether we are intubating the child or we are intubating the adult patient. In case of pediatric patients, we like to use Miller blade, which is a straighter, thinner, and this blade can be used in infant and young children. In case of Miller blade, we directly lift the epiglottis, and it provides better control of tongue. Whereas in case of Macintosh blade, it is more curved, it is more wider, and this blade can be used in older children and adults. So when we are using the Macintosh blade, we should need to put the tip of the blade into the vallecula. We don't directly lift the epiglottis. We put the blade into the vallecula, and then we try lifting the epiglottis. This blade curves around the mouth, so it puts the tongue away from our vision. These are the different sizes of laryngoscope. In case of preterm, we can use 000 Miller blade. In case of term, and we can use 0 to 1. In case of infant and toddlers, we use size 1. Preschool children, we can use Macintosh blade size number 2, and school children, we use 2 to 3 Macintosh blade size. Now, how do we find the appropriate size endotracheal tube? So if we are using an uncuffed tube, we can use the formula age in years by 4 plus 4. And if we are using a cuffed tube, we can use the formula age in years by 4 plus 3. So after calculating the definite size, we should always keep a size above and a size below of the calculated size. And depth of insertion of the endotracheal tube, for this again we can remember this by using this formula age in years by 2 plus 12, or we can roughly multiply the internal diameter. This internal diameter is always mentioned on the packet, and this is how the size of the endotracheal tube is written. So we can always use this internal diameter and multiply it by 3 to assess the depth of insertion. And cuff pressure should be always less than 20 centimeters of water. These are again the sizes of endotracheal tube. So by the inner diameter of the endotracheal tube, we define the size of the endotracheal tube. So for the inner diameter, there is a corresponding outer diameter. So if it is the uncuffed endotracheal tube or if it is the cuffed endotracheal tube, these are the corresponding external diameter or the outer diameters of the endotracheal tube. Now, sometimes we are not able to negotiate the tube as it is, so we need stillets. So these are the stillets which aid into the negotiation of endotracheal tube inside the glottic opening. And sometimes we are not able to visualize the glottic opening as such. In that case, we can use this elastic bougie. Even if we are able to see the tip of the epiglottis and not the complete glottic opening, in that case we can use this elastic bougie. We can slide along the epiglottis, and we can put it inside the airway of the patient, and then we can railroad the endotracheal tube through this elastic bougie. We need equipment like ambu bag for mask ventilation of the patient. So if it is a neonate, then we need 200 to 300 ml of ambu bag size. In case of infant and young children, we need 450 to 500 ml. In case of adolescents and older children, we need 1000 to 1500 ml. How do we calculate the appropriate mask size and how do we hold the mask? This is very important because creating a proper seal is very important for mask ventilation. So if you don't remember the mask size, that is okay. If we don't have to remember the mask size, we should just pick a mask and we should keep the mask slightly on the airway, on the nose and mouth of the patient. The triangular area of the apex of the triangle, this should be on the bridge of the nose, and this round area should be on the chin. Mask should properly cover the nose and the mouth area. It should not be too tight or it should not be very large. So this is how we can calculate the mask size. Once we have calculated that this is the appropriate size mask, then we need to hold the mask on the airway, nose and mouth of the patient. So this is the ENC technique that we use to hold the airway on the mouth of the patient. So this is the C of this technique and this is the E of this technique. So with the C, the thumb and index finger slightly presses on the nose and mouth of the patient mask. And with the E, we try to extend the airway of the patient. We try to lift the chin of the patient. So whenever we using this E, then these fingers should be placed on the bony prominence of the patient, not on the soft tissue of the patient. So if we are placing on the bony prominence, then and then we are lifting, so it will help in intubation of the patient. And if we are not placing on the bony prominence, it will lead to compression of the soft tissue of the patient. So we can use two-hand technique also. In this two-hand technique, we uses thumb. With the thumb, we presses the mask, and with the fingers, we lift the chin of the patient. So we can use any of the technique according to your expertise or according to the availability of aiding staff to you. So you can use any technique according to these situations. Now, other adjoint equipments then that we require are the suction apparatus. In case of suction apparatus, we need appropriate size of the suction tubes. So, if it is the endotracheal size 5, then these are the corresponding size. If it is 9, this is the corresponding size. And these are color coded as well. So, if we don't remember according to the size, we can remember according to the color of the suction catheter. And the suction pressure should always be around 80 to 120 millimeters of mercury. We should not go more than this. And then other equipments then we need are the oropharyngeal airway. So this is the Goodell airway, which comes in the sizes of 00 to 4. So it is 4 to 20. Goodell airway is 4 to 20 centimeter in length. Goodell airway is also color coded. So if we don't remember the exact size, or if we remember the color, then we can use this. And if we want to know out of these available airway to us, which one is of appropriate size for the particular patient, then you can always keep the tip of the airway at the middle of the mouth on the lips, and the distal end of the airway should be on the angle of the mandible, and the curvature should be facing upward. So this is how we can get to know which size airway we need. So this is how we can calculate the size. Other adjacent equipments that we require is dynaplast or the micropore for securing the endotracheal tube, or to monitor the pulse oximetry, or to graph we need monitors. So after that, or whether I should say before that, before attempting any procedures that you are going to do, you should always keep in mind the personal protection equipment is very important. So in case of COVID time, these personal protective equipments should be ready. The pre-medications that we need are tranquilizers, opioids, non-opioid analgesics, or dissociative agents like ketamine, anticholinergic agents like glycopyrrolate or atropine, or we need antacids like H2 blocker, ranitidine, metoclopramide. So if we are using midazolam, or if we are using ketamine, in case of midazolam or in case of ketamine, we can use any route, like we can use intravenous or we can use intramuscular. So the dose is according to the route that we are using, and the onset of time is also according to the route that we are using. So we should keep in mind for which route, which dose should be given to the patient for the appropriate effect of the drug. Now we need drugs for resuscitation if we face complications. We need epinephrine loaded syringes, which should be in the dilution of 1 is to 10,000. We can give it in the dose of 0.01 mg per kg IV. Or in case of bradycardia, atropine should be ready, should be given in the dose of 0.02 mg per kg. IV fluids we need, then we need calcium gluconate and hydrocortisone. In case of COVID, we prefer doing rapid sequence intubation. So the caution in case of rapid sequence intubation, we always give pre-calculated dose. So when we are using muscle relaxants in case of rapid sequence intubation, the pre-calculated of the muscle relaxant should not be given just like that. First, we should always keep we should check the mask ventilation of the patient. If we are able to mask ventilate the patient, then only we should give the neuromuscular agents. Because if we have not checked it and we have given the neuromuscular agents, and if we are not able to ventilate the patient, then it will be catastrophic for us. So we should always first check ventilate the patient, and then we should give the muscle relaxants. The drugs that can be used for rapid sequence intubation can be etomidate or propofol or ketamine or fentanyl. These are the induction agents. Then we can use the depolarizing paralytic agents like succinylcholine, or we can use non-depolarizing paralytic agents like rocuronium or vecuronium. So these are the corresponding doses of the corresponding drug. So what kind of drug you can use? It depends on the availability of the drug, And again, it depends upon the condition of the patient. So we can choose any of these drugs according to our expertise, according to availability, and according to the condition of the patient. Now, before attempting laryngoscopy, we need to pre-oxygenate the patient. So use 100% oxygen for 3 to 5 minutes. Why? Because it increases the safe apnea time of the patient. If patient is spontaneously breathing, then we can use non-rebreather mask or the nasal cannula for this pre-oxygenation. But if the patient is in apnea or gasping or patient is not breathing, in that case, we can use bag and mask ventilation. Step one, proper positioning of the patient. So always check the endpoint of the positioning. Step two, hold the laryngoscope. For this, we should try holding the laryngoscope into the non-dominant hand because we need to manipulate the airway of the patient for opening of the airway or other kind of manipulation that is required. So try holding the laryngoscope into the non-dominant hand. So how do we hold a laryngoscope? There are two techniques which have been described. One is the classic technique, and there is a other better way to hold the laryngoscope, grasping the handle near the hinge as shown with the thumb, stabilizing the base of this blade, and affords better. It says it affords better precision and control. But again, for holding the laryngoscope, you can use any way you are comfortable with because you are the one who is going to do the procedure. So you should be comfortable with the technique that you are using. So you can use any technique you are comfortable with. Then open the mouth. You can use scissoring technique for opening the mouth, pressing the lower lip of the patient with the thumb, and the other fingers we can use to open the airway. Then introduce the laryngoscope. We should always introduce the laryngoscope from the angle of the mouth. So never go in between. Always introduce from the angle of the mouth of the patient. Then this is the way we insert the laryngoscope, and we should go along the angle, and then we should always see where we are going. The procedure should be not done in a very hurried manner. You should do it calmly, and you should keep seeing what structures you need to see while introducing the laryngoscope inside the mouth of the patient. This is the technique which is wrong. We should always use the angle of the mouth. Then we already know what we are looking for. So once you are inside the mouth, you should identify your landmarks. And this is again this is the blade that we are advancing inside the mouth of the patient. And this is the picture which is showing the use of cricoid pressure. In the older RSI technique, we used to use the cricoid pressure, but then again, it was found that using cricoid pressure distorts the anatomy, and that makes identification of the anatomical landmarks very difficult. So in case of latest developments, we try avoiding the cricoid pressure. We don't use cricoid pressure. So this is again the image that we need to identify. These are the anatomical landmarks that we need to identify. Always engage the tip of the blade into the vallecula, and the type of laryngoscope that we are using, according to that, you should do the lift. If we are using a Miller, lift the epiglottis directly. If you are using a Macintosh, then put the blade into the vallecula and then lift the epiglottis. So this is again the mechanism showing the lifting of epiglottis. You should always, when we are putting pressure on when we are holding the laryngoscope, the handle of the laryngoscope, and we are trying to lift the epiglottis, we should always use our shoulders for this technique. We should avoid using wrist, because if we are using wrist, if we are moving wrist, then we might put pressure on the upper lip of the patient, and we might lead to trauma, can cause trauma. So always try and using your shoulders for lifting of the epiglottis. So this is the technique of showing insertion of endotracheal tube. The stillet is already in place. So this is the endotracheal tube which is going inside the glottic opening, and this is how we secure the airway of the patient. And once we have put the endotracheal tube inside the airway, then we need to check whether it is in the correct place or not. So for that, we can assess clinically by bilateral chest rise with each ventilation, or we can auscultate, and we should hear for equal air entry in bilateral chest, and we should hear that there should be no breath sounds over the abdomen. And if we are seeing the monitor, then the SpO2 patient or SpO2 of the patient should be more than 90%. And if we are using capnograph showing the waveform or the color change, or if we are using a chest X-ray, then our tube should be more than above 3 centimeter the carina. So this is the waveform that we are looking for. If we have properly intubated the patient, if we are at the right place, so this is the kind of waveform. This is the capnograph we'll be able to see on the ventilator or the monitor. And this is the chest X-ray. With this, we can see the tube should be 3 centimeter above the level of carina. So this is how we can definitely say whether we are at the right place or not. So if we are not able to negotiate the tube, then in these situations we can use the laryngeal mask airway. Laryngeal mask airway has found its position into the difficult airway situation. It should be there into the airway cart. So if we are using a laryngeal mask airway, in that case, first we need to prepare, deflate the cuff of the laryngeal mask airway and lubricate this dorsal surface of the laryngeal mask airway. Hold it into the pen holding position, and then insert the airway along the hard palate and roof of the mouth. So this laryngeal mask airway slightly move inwards. This laryngeal mask airway sits on the opening of the airway. It does not go inside the glottic opening, but it sits on the airway area. And once we have placed the laryngeal mask airway, then we should inflate the cuff. There will be slight upward movement of the laryngeal mask airway, and you will be able to palpate a swelling in this area. So these are the placement. This is the placement technique, and this is how we can uh, assume that the laryngeal mask airway is at its place. And for checking, we can again use the bilateral chest rise to see the ventilation of the patient, whether patient is being ventilated or not. So once we have inserted the endotracheal tube or we have used the laryngeal mask airway, we need to secure our airway in place. So for that, we can use Dynaplast. So securing is very important, otherwise it will lead to displacement of the endotracheal tube or the laryngeal mask airway. So these are the technique with which we can secure the endotracheal tube. We can take a part of it, we can slit between two, and when we are pasting it on the airway of the on the upper lip of the and lower lip of the patient, we can paste from maxilla to mandible or maxilla to maxilla, so whichever technique you want to follow. So securely place the endotracheal tube using this Dynaplast. So this is how we secure the endotracheal tube. Again, securing the endotracheal tube. So there is no procedure which is without complications. In case of laryngoscopy and intubation, we might face hypoxemia or bradycardia, or we can face hypertension, or there can be laryngospasm or bronchospasm, or there can be trauma to mouth, larynx or vocal cord, or we can do esophageal intubation, which might lead to perforation as well, or there can be tracheal perforation if we are using too much force, or there can be emesis, which can lead to aspiration and cardiac arrest. So if there is an acute deterioration in post-intubation period, so we should always rule out DOPE. D is for displacement or misplacement. O is for obstruction of the endotracheal tube because of the secretions or because of the blood. P is for pneumothorax, or E because of the equipment failure or the ventilator failure. The common pitfalls that occur are can be because of rocking movement of the laryngoscope, or if there is inability to visualize the glottic opening, like blade inserted too deep, or there is an improper positioning. So first of all, improper positioning. So achieving proper position is very important. Always focus on achieving the position, and you should always go slowly. We should not do procedures in a hurried manner. Always keep looking at the structures, because in case of pediatric, there are many times when we go too deep and we miss the glottic opening of the patient. Or we can do right main strip endotracheal insertion. We have inserted the tube too deep, so only right lung is ventilating, not the left side of the lung. Or we can do multiple attempts if we are not well versed with the procedure, expertise is not there. So try keeping the attempt less than 3 within 20 to 30 seconds. Or for the equipments or for any procedures, you should always have a checklist. Whatever procedure you are attempting, always try and have a checklist, and before attempting the procedure you should always check according to this list. So it will lead to more success of the procedure rather than failure. So what is the difference in case of COVID-19? In case of COVID-19, personal protection equipment, very important. This should be our first priority. After that, experienced personnel should perform the procedure. So these patients are not basically for learning. So always an experienced person should do the procedure. We should always avoid awake intubations, and we should always inflate the cuff of the endotracheal tube once it is inserted before the starting of bag and mask ventilation. And we should use inline suction catheters. We should not use open catheters. Always inline suction catheters should be used in case of COVID patients. So these are the innovations which really help us in intubation of the patient. This is the video laryngoscope. So when we the blade of the video laryngoscope is just like any other laryngoscope, like a Macintosh blade. So when we insert it inside the mouth of the patient, and when we keep seeing the airway of the patient, it will be displayed here, and we will be able to identify the structures. And these are the viral filters. The take-home message for a lecture would be, in case of pediatric intubation, it is an important skill in the management of critically ill children. So we should master this skill. The knowledge of relevant anatomy is very important, and appropriate equipment should be kept ready at all times in a pediatric ICU. Crash cart. Medications are an important component during intubation. So the type of medications and the dose of medications we should keep in mind. There should be stepwise insertion technique should be performed for optimal success. Post-intubation care is an essential part of intubation process, and complications should be anticipated early and should be treated early. So these are the references for my presentation. Thank you. Hello.
Thank you, Dr. Kavita, for the excellent presentation.
Thank you, ma'am.
I think there is no question regarding your talk. So thank you.
Okay, ma'am. Thank you for
the
providing the opportunity.
Thank you. So for next talk, I invite Dr. Yashwant Rao. And Dr. Yashwant Rao is HOD and professor at the Department of Pediatrics, GSVM Medical College, Kanpur. And he will be talking about the initial settings of ventilation and how to titrate.
Am I audible?
Yes, Dr. Yashwant.
The screen is visible, ma'am?
Yes, it's visible.
Yeah. First time my screen is visible.
Yes.
Thank you so much, ma'am. My talk is on invasive mechanical ventilation, almost very much covered by Thapar sir and other people. So basically, in this presentation, I'm going to share some ideas about initial settings and how to titrate the ventilatory setting. Before that, I'm going to start with a case, a 10-year-old male obese patient, fever for 5 days and body ache, myalgia for 5 days. He was COVID positive, RT-PCR positive 5 days ago, and that patient, they started developing breathing problem and cough 3 days ago. And already Thapar sir told that initially we have to start oxygen. Then if requirement is increasing, then we have to give NIV support. And even on NIV support, patient's respiration is compromised, shallow respiration or very labored breathing, then we have to shift the patient to the invasive ventilator. So this patient started developing hypoxemia even on oxygen. So patient shifted to non-invasive support, that is HFNC or BiPAP. But even on NIV support, oxygen requirement increased to 80%. And we all know and we were taught like that, FiO2 should be below 60. On NIV support, pressure support was 12/8. 12 was the PIP and 8 was the PEEP. Initially, we start with the 8 PEEP. Then, even on that, means 12/8 support and 80% FiO2, child was sleepy and appeared tired. Sleepy means ki child has started developing CO2 retention. Tired means ki respiratory problem. Shallow respiration is there. Child has started developing tachycardia and tachypnea. 10-year-old child, respiratory rate should be around 20, but it is 50 even on NIV, non-invasive ventilation, and there is tachycardia, which should not be there. So we are giving support, non-invasive ventilatory support, to maintain all the vitals in the physiological range. Means ki heart rate should be below less than 100, respiratory rate should be around 20, but child was deteriorating. Chest movement appears shallow. Bilateral crepitations were present, and on 80% FiO2, 12/8 pressure, pulse oximetry was showing saturation of around 89 to 90%, which is less. We assume 92 to 95 at least. And very important part, whenever child used to drink some water, taking out the mask, it drops to 80%. But as rapid SpO2 is dropping after with off the mask, it means ki lungs are very bad. And child was not able to eat anything because he was not able to drink water because he developed hypoxemia. So he was not able to eat since 1 day. Means ki child was lungs conditions were very bad. So basically, in the previous presentation, Thapar sir told ki initially we have to give oxygen for any hypoxemia, but when there is hypoxemia and hypercarbia, but respiration is okay, then we have to start NIV mode. But if respiration is disturbed, then we have to start the invasive ventilation. And ma'am already intubated the patient, so I am going to start the ventilation. So what we are going to cover on ventilatory setting is ventilatory mode, respiratory rate, tidal volume, IE ratio, inspiratory time or IE ratio, FiO2 and PEEP. One by one is ventilatory setting. So, among the ventilatory setting, I will discuss first the different type of the mode. So which mode is the best mode? Thapar sir already covered everything, but just to brief, mainly we are dealing with the 3 mode: CMB mode, ACMB mode, and SIMB mode. Very important part is CMB mode. Here, every breath is delivered by the ventilator, and it has not any relation with the patient's breath. Means, suppose ventilator is giving breath and patient is expiring, so pressure will be increased due to fight. Pressure will be increased, and patient may develop pneumothorax. So CMB mode should be used when there is no respiration, no effort. Respiratory muscle paralysis, then we can use CMB mode. Nowadays, the new ventilators are coming without any CMB mode. So mainly we are going to use ACMB mode and SIMB mode. ACMB mode, and what is the difference between ACMB and SIMB? Both are the same because they are not going to fight with the patient's breath. They are going to support the patient's breath. In SIMB mode, whatever the frequency we are setting, suppose हमारा बच्चा है 10 साल का, we have set the frequency at 20. So in 20. So in 1 minute, there will be, in every 3 seconds, one respiration will be there. So patient ventilator is going to support only 20 spontaneous or non-spontaneous breath. But in ACMB mode, 20 breaths will be given and patients, all the breath will be supported. So in ACMB mode, what the problem will be, there the problem of hyperventilation. Due to support of each and every breath, hyperventilation will be there and CO2 wash out will be there, and you all know patient will develop alkalosis and lots of problem may start with ACMB mode. So ACMB mode better to during weaning period or there is respiratory paralysis, then we can use ACMB mode. But in SIMB mode, only set frequency is supported, rest of the spontaneous breath patient is taking, and ventilator is not going to fight with the patient's respiration. So basically, even me and I have been taught like that, the SIMB mode we are using and we are very happy with the SIMB mode. And very important part, whatever be the mode you are familiar, you should use that mode. Don't jump up to the newer mode like PRVC and other mode, because you have to take care of many more things. And this is the simplest mode, SIMB mode. Two things are there. SIMB, so whenever you are going to start the ventilator, so if you put the finger on the mode, so lots of mode will come. Suppose you have selected SIMB mode, then ventilator will ask you it should be pressure limited or volume limited. So what the pressure limited? Ventilator क्या करता है? Basically, it gives the positive pressure ventilation, positive breath देगा. So it should be pressure limited. मतलब whatever the pressure we are setting, suppose 18 or 20. So when the pressure in the circuit reaches 18 or 20, ventilator will stop giving breath. So this is pressure limited. Means कि जितना pressure हमने set किया, उतना pressure पहुंचने के बाद ventilator inspiration को बंद कर देगा. अब expiration start होगा. Second is volume limited. तो जितना वॉल्यूम हमने दिया, सेट किया, उतना वॉल्यूम देने के बाद वेंटिलेटर विल स्टॉप गिविंग ब्रेथ. तो लाइक जैसे हमारा बच्चा 30 किलो का है, 10 साल का है, तो हम प्रेशर लिमिटेड में 20 प्रेशर से सेट कर सकते हैं. वॉल्यूम लिमिटेड में हम 6 to 8 ml पर केजी से हम देते हैं. तो बेसिकली वी स्टार्ट विद द लोअर लिमिट. तो 6 ml पर केजी, 30 kg है तो 180 ml पे हम सेट कर सकते हैं. तो फ्रेंड्स, सबसे पहले हमने सेट किया SIMB मोड. सेकंड पे हम सेट करते हैं कि इधर प्रेशर लिमिटेड और वॉल्यूम लिमिटेड. बोथ आर इक्वली इफेक्टिव. वेरी इंपॉर्टेंट पार्ट इज कि सपोज वी सेट द प्रेशर मोड, बट इफ लंग्स आर वेरी बैड, तो that pressure will be achieved very early, but volume delivered will be less. So if you are using pressure mode, you should measure the volume. At least 180 ml volume should reach inside the patient's lung. And if we are using volume mode, so we should check the pressure, peak pressure, and peak pressure should not go beyond 30. Otherwise, pneumothorax may develop. Then, so we have discussed the mode. So we are going to start with the SIMB mode. In SIMB mode, it's up to you कि pressure limited or volume limited. Pressure limited usually हम neonate पे use करते हैं. Volume limited usually हम pediatric patient पे use करते हैं. Now coming to the respiratory rate. So we have already discussed कि in neonate respiratory rate is 40 to 60. So we keep the ventilatory rate between 40 to 60. 1 month to 1 year we keep between 25 to 30. 1 to 5 year 20 to 25. 5 कम करते जाइए. And adult में जैसे 12, 13, 14 पे हम करते हैं. Adolescent में 15 से 20 के बीच में करते हैं. And toddlers and pediatric patient में 20 से 25 के बीच में हम करते हैं. Usually the ventilator which we are having in the government medical college which we are having, usually we don't have EtCO2, but if you are having that facility, you can use EtCO2 to set the rate. Because if you increase the rate and increase the expiratory time, then CO2 will be false. If EtCO2 showing higher reading, you can set your respiratory rate according to EtCO2, but EtCO2 is not there in our ventilator, so rate should be set like that. Now, coming to the tidal volume or inspiratory pressure, I have already covered that inspiratory pressure should be started around 20 centimeter of water, or in pressure limited, or if we are using volume limited, so 6 ml per kg, that is 180 ml. And if we are using volume, so we should monitor the pressure. If we are using pressure, then we should monitor the volume. Rest part I have already covered. So this was about tidal volume and inspiratory pressure. Now coming to the IE ratio, friend, this is very important, and don't go to the very here and there. Basically, start with IE ratio of 1:2 to 3. मीन्स कि अगर हमने अपने बच्चे का रेस्पिरेटरी रेट 20 सेट किया है, 10 साल का बच्चा है, 20 सेट किया है, तो 3 सेकंड की एक साइकिल हुई. तो इफ वी सेट आई 1 सेकंड, तो ई विल बी 2 सेकंड, तो 1:2. इफ वी पुट आई 0.8, तो 2.2, तो 8 तो 1:3, 1:2.8, 2.9 हो जाएगा. तो बेसिकली वी हैव टू कीप द आई रेशियो 1:2 to 3. दिस इज इंपॉर्टेंट. Since in neonate respiratory rate is around 40, तो 1 साइकिल कितने देर की हो जाएगी? 1.5, 60/40, 1.5 सेकंड की. तो यहाँ पे अगर हमने 1 सेकंड सेट कर दिया, तो E के लिए केवल 0.5 सेकंड मिलेगा, तो there will be CO2 retention. So important part is 1:2 to 3. So to keep 1:2 to 3, I will like to keep 0.5. तो एक सेकंड की हमारा ई हो जाएगा, 0.5 का आई हो जाएगा, तो 1:2 का हो जाएगा. तो जितना छोटा बच्चा होगा जिसका रेट हाइयर होता है, उसमें आई कम रखते हैं, और जितना बच्चा बड़ा होता है उसमें आई हम बढ़ा के रखते हैं. नाउ कमिंग टू द FiO2. Friends, FiO2 depends on the status of the patient. If patient is coming with SpO2 of 30, 40, 50, so I will start with 100%. If patient is with us since many days, I will not allow the child to develop hypoxemia. So I would like to start with 60, 70, 80. Actually, but whatever FiO2 you are using, gradually come below 60, because superoxide or hyperoxia injury should be avoided. Now coming to the PEEP. Friends, this is very important part during the COVID epidemic. PEEP and COVID pneumonia, lungs become very stiff, and due to stiffness and loss of surfactant from the alveoli are getting collapsed. Suppose our 25%, 50% lungs are collapsed, they are not taking part in the ventilation. Circulation may be there, and our pulmonary capillaries are getting thromboed. So it further aggravate the condition. So if we are having PEEP, basically they try to keep the lung inflated, alveoli inflated at the end of expiration. So in COVID pneumonia, if you are not going to apply PEEP, at the end of expiration, alveoli will be getting collapsed. If alveoli getting collapsed, each time you require very high pressure to further inflate the lung. So friends, in normal lung or mild pneumonia, we used to keep the PEEP 3, 4, 5. But in COVID, start with 8 centimeter of water and titrate according to. But if still child is not improving, we can increase the PEEP up to 12. Usually we don't go beyond the 12. What it does, I have already told. Basically recruits, means कि जो alveoli collapsed हैं, वो सारे इन्फ्लेट हो जाते हैं, वहां पे ऑक्सीजनेशन होता है, सर्कुलेशन होता है, तो ऑक्सीजन रिक्वायरमेंट कम हो जाता है, हमारा सरफेस एरिया बढ़ गया ड्यू टू PEEP, and it takes the lungs to the better part of the compliance, which I am going to tell you in the next diagram, and it prevents atelectotrauma. What do you mean by atelectotrauma? Barotrauma, volume trauma. One is atelectotrauma. All the time at the end of expiration, if alveoli are getting collapsed, and with inspiration they are getting ballooned, so all the time if PEEP is not there, there will be injury due to collapsing and inflation. So if we have good PEEP, it will prevent atelectotrauma, improve the oxygenation, and work of breathing will be decreased. But if PEEP is excess, suppose if PEEP is high, lungs are much inflated, it will compress the heart. If it will compress the heart, venous return from superior vena cava, inferior vena cava will be decreased. If return will be decreased, then stroke volume will be decreased and BP may fall. So due to decreased venous return, hypotension is the very important problem. It should be avoided, and due to high PEEP, barotrauma is the quite possible. Other settings, basically, if you are using ventilator frequently, so you can set trigger. Basically, triggers are two types. One is flow trigger and second is pressure trigger. What do you mean by trigger? Trigger is basically sensed by the ventilator because sensors are there, and when they sense the patient is going to start the respiration, ventilator will give the support in ACMB and SIMB mode. So they are two types. One is flow and second is pressure trigger. Pressure trigger. So when the patient will start ventilation, there will be negative pressure inside the circuit and it will be sensed by the ventilator, and immediately ventilator will start the patient's, support the patient breath. But very important is basically nowadays we are having the event and dragger. They are basically having flow trigger, and usually we used to keep the flow trigger around 2. You can keep flow trigger between 2 to 4. It's appropriate. Don't touch the trigger much, and don't allow the sisters and other person to touch the trigger. Should be set around 2 to 3, but only if you are very much using ventilator, then you can set the trigger, because it supports patient's breath is very high, 70, 80. You have given sedation and all the breath is being supported, then what hyperventilation will be there, and you have increased the flow trigger 4. So the weaker breath will not be supported, so hyperventilation can be avoided. So friends, better to set the not to set the trigger, and it should be kept between 2 to 4. Rise time is the out of total time, in how much time all the inspiration can be given by the ventilator. All the volume will be delivered to the patient's lung is 5 to 10%. Don't touch much. So what we did, madam has intubated the patient. I have put the ventilator, and I have decided to start the SIMB pressure control. PIP हमने 22 का रखा, PEEP हमने 8 का रखा, रेस्पिरेटरी रेट 18 का, मींस कि हमारा टोटल साइकिल आई और मतलब वेंटिलेशन की साइकिल 3.3 के आसपास हो गई, एंड आई हमने 1 रखा, तो ई अपने आप 2 हो जाएगा, तो आई ई रेशियो 1:2 हो गया। FiO2 हमने 80% से स्टार्ट किया। ट्रिगर अभी हमने 0 रखा कि भाई जितना ज्यादा वेंटिलेटर का जितना ज्यादा पेशेंट्स लेगा सबको सपोर्ट करेगा। एंड वी हैव स्टार्टेड सेडेशन, मिडाजोलाम और फेंटेनिल। यूजुअली वी डोंट हैव फेंटेनिल एंड मॉर्फिन, so we used to sedate with the midazolam. Basically we have put the ventilator put the patients on ventilator. Why we have put the patients on ventilator? To make all the vital in the physiological range, means ki tachycardia should improve and tachypnea should improve, respiratory effort patients GC improve, patients जो डल था वो improve कर गया, patient active हो गया, हाथ पर चलाने लगा बच्चा, इसीलिए हमने रखा था। अगर ये सब वापस आ गया, इस मीन्स की हमारा वेंटिलेटरी सपोर्ट अच्छा था। हमने चेस्ट राइज देख लिया, EtCO2 अगर है तो वो हमने देख लिया, पल्स ऑक्सीमीटर में SpO2 देख लिया, इट शुड बी बिटवीन 93 to 95। वेंटिलेटरी पैरामीटर हमने क्या देखा, चूंकि हमने प्रेशर पे रखा था, तो आई वुड लाइक टू सी द वॉल्यूम कि ऑन 22 प्रेशर जो टाइडल वॉल्यूम है ये 180 ml जा रहा है कि नहीं जा रहा है। एंड आई वुड लाइक टू सी द पीक प्रेशर इन द सर्किट, मीन एयरवे प्रेशर। I would like to see the minute volume. Minute volume is tidal volume into the respiratory rate, and waveform we can see. ABG is not needed all the time because this is going to harm the patient. All the time you are giving painful stimulation, patients may deteriorate, and हाथ पर चलाने से कई बार extubation भी हो जाता है. So don't try to do ABG all the time. Always try to do ABG because SpO2 we are getting by pulse oximeter. If you are going to see the acid-base disorder and other thing, gap वगैरह, then you can do ABG. If vital signs are not improving, then either our whatever we have set on the ventilator may be inappropriate. That's why vital signs are not improving. Means ki settings are not right, and patient is either under sedated. Means ki all the time patient is fighting, and secretions are interfering the ventilation. कई बार होता है कि due to humidifier उसमें पूरा सर्किट में पानी आ जाता है तो इट विल ब्लॉक, खड़खड़ाहट की आवाज आती है. पेशेंट्स का ईटी ब्लॉक हो गया, ईटी में सिक्रीशंस हैं, चेस्ट राइज एडिक्वेट नहीं है. मतलब अगर एडिक्वेट नहीं है तो वी हैव टू इंक्रीज द पीआईपी. हम 22 से 23, 24, 25 जाएंगे, और अगर एक्सेसिव चेस्ट राइज है तो हम पीआईपी को कम कर सकते हैं. कई बार क्या होता है कि हमने इंट्यूबेट किया एंड वी fail to put the Goodell's airway, and patients will bite the endotracheal tube, and there will be very much volume will be delivered, because due to clenching of the teeth 22 pressure आराम से मिल जाएगा, उसको पहले ही मिल जाएगा, तो ventilator will stop giving the breath. So friend, we have to see our all the tubings if patients is not improving, and all the secretions and all the tubing should be clear. How to optimize the ventilation? Basically, this graph is showing, this is pressure volume loop. This is showing, you can see I am moving the cursor. This is showing what should be the optimum PEEP and what should be the optimum PIP. So friend, this is the, you can see here we are increasing the pressure, but volume is not increasing much. Very minimal increase in the volume. मतलब हमारा वेंटिलेटर का प्रेशर यहाँ से यहाँ तक गया, लेकिन वॉल्यूम में राइज सिर्फ इतना हुआ. बट यहाँ से देखिए ए बार के बाद से वी हैव इंक्रीज द प्रेशर एंड अप टू सी. यू कैन सी कि सेम प्रेशर से यहाँ पे इतना वॉल्यूम राइज हुआ, बट यहाँ से लेके यहाँ तक में वॉल्यूम राइज इतना हो गया. This is the compliant part of the lung, and this is known as lower insufflation point, and we should keep the PEEP here. And you can see starting of the C, from here you can see with increase in the pressure, volume increase is very minimal. This is the beaking effect. This is known as upper insufflation point. Means कि अगर आपने PIP 22, 23, 24 यहाँ तक कर दिया, उसके बाद अगर आप प्रेशर बढ़ाएंगे तो वॉल्यूम तो नहीं बढ़ेगा. Due to stiff lung or lungs have become very bad, volume तो नहीं बढ़ेगा, but volume trauma and barotrauma, pneumothorax may occur. So we should try to keep our PIP here, and we should keep our PEEP here. Now, tidal volume is low or minute ventilation is low. Ventilator is showing alarm and it is low. So what to do? हमने प्रेशर सपोर्ट पे रखा था, एंड टाइडल वॉल्यूम मतलब 180 हमने 180 होना चाहिए, एंड ये आ रहा 130, 140, क्योंकि लंग्स आर वेरी बैड, एंड PIP on 22 PIP वॉल्यूम इज वेरी लेस. तो हम क्या करेंगे? We will increase the PIP. We should check the tubings for any leak. Compliance means कि lungs are very bad. This could be the, so we should increase the PIP. Second, sudden rise is the peak pressure. हमने देखा वेंटिलेटर लॉन्ग सेट किया था पीक प्रेशर का, एंड इट इज शोइंग. तो ये तभी होता है जब ट्यूब कहीं किंक हो जाए, या पेशेंट बाइट कर ले, सिक्रीशंस भर जाए, या पेशेंट्स के लंग में ब्रांकोस्पाज्म हो जाए, सम टाइम ड्यू टू फॉरेन बॉडी, ड्यू टू एंडोट्रैकियल ट्यूब और ड्यू टू सिक्रीशन ब्रांकोस्पाज्म, तो हम उसको नेबुलाइज करेंगे. अगर सिक्रीशंस है तो वी शुड सक्शन, एंड अगर क्लिंचिंग है तो हम गुडल्स एयरवे डालेंगे. कहीं पे ट्यूब किंक हो गई है तो हमें उसको भी सही करना है. What the practical problem? Basically, I did a lot of work in the adult COVID ICU. Basically, जब स्वीपर झाड़ू वाड़ू लगा रहे होते हैं, या सिस्टर जब जाती है अलार्म देखने के लिए, तब ये सब प्रॉब्लम ज्यादा आती है. वो झाड़ू से कस के पोछा मारा, पाजला ट्यूब वेंटिलेटर की पहिए के नीचे आ गया, किसी ने खींचा, वो ट्यूब ब्लॉक हो गई. तो you should check all the things. So with this ventilatory support, we should target the blood gas, not optimum, but near the optimum, and it is 7.3 to 7.5. PaO2 55 to 80 is okay. PCO2 45 to 50. 55 is okay. Lactate should be, but lactate should be less than 4. Electrolyte should be normal. How to optimize the blood gases? Suppose PaO2 is less, means कि less than 55. तो ऑक्सीजनेशन बढ़ाने का थापर सर ने बहुत बढ़िया बताया था. हाउ टू इंक्रीज द ऑक्सीजनेशन? तो वन की ऑक्सीजनेशन बढ़ाने के लिए हम लंग का सरफेस एरिया बढ़ा दें. तो तो इसके लिए हम पीप बढ़ाएंगे। दूसरा, हम इंस्पिरेटरी टाइम बढ़ा दें तो ज़्यादा टाइम मिलेगा लंग में ऑक्सीजन और CO2 एक्सचेंज के लिए, तो आई को बढ़ा दें। तो पहला पीप बढ़ा दें, दूसरा आई को बढ़ा दें, इंस्पिरेटरी टाइम को बढ़ा दें, तीसरा हम FiO2 को बढ़ा सकते हैं। सम टाइम जब आई ई रेशियो बराबर हो जाए या आई को बराबर बढ़ा दे हम, तो इसको इनवर्स रेशियो वेंटिलेशन कहते हैं। नॉर्मली 1:2 होता है, और अगर ये 1.2:1 हो गया आई ई रेशियो, तो ये इनवर्स रेशियो वेंटिलेशन। चौथा काम होता है कि हम चेंज द पोजीशन, हम लैटरल या प्रोन वेंटिलेशन कर सकते हैं 12 से 16 घंटे के लिए। 24 घंटे में हम लोगों ने 2-3 एडल्ट पेशेंट पे ट्राई किया था, बट वी कुड नॉट सेव ऑल 3 पेशेंट्स, बट वी कैन definitely we got the improvement in the oxygenation by proning, but we should be very much conscious because proning is not a very easy way. It's very difficult to put the child in the prone position. Sedation should be very proper, otherwise child accidentally may extubate. तो ऑक्सीजन इंप्रूव करने के लिए हम पीप बढ़ा सकते हैं, आई बढ़ा सकते हैं, हम प्रोन कर सकते हैं, और FiO2 टेम्पोरली केवल बढ़ा सकते हैं। 4 चीजें। अगर देयर इज CO2 रिटेंशन, तो फ्रेंड हम CO2 रिटेंशन के लिए हम वॉल्यूम ऑफ वेंटिलेशन बढ़ा दें तो हम रेस्पिरेटरी रेट बढ़ा सकते हैं, या दूसरा एक्सपिरेटरी टाइम हम बढ़ा दें तो हो सकता है। एंड ट्यूब साइज सही होना चाहिए, सिक्रेशन सारे हटा दें, ब्रांको स्पाज्म नहीं होना चाहिए, तो वी कैन wash out the carbon dioxide from the blood. Ventilatory alarm, basically nowadays alarms are already set, but मतलब ड्यूरिंग रूटीन डे नियोनेटल वेंटिलेटर में नियोनेटल अलार्म सेट होता है, पीडियाट्रिक में पीडियाट्रिक, एडल्ट में एडल्ट, बट नाउअडेज वी आर यूजिंग यूनिवर्सल वेंटिलेटर। तो सपोज हमने 180 ml का वॉल्यूम टारगेट किया था, तो आई विल लाइक टू कीप द अबव हायर वैल्यू। तो 30 kg का है तो 8 ml से ऊपर हम नहीं जाना चाहेंगे, तो 8 24 240 ml अपर, तो हम 250 ml अपर लिमिट सेट कर देंगे। ऐसे ही 6 ml पर kg 180 है तो 150 ml हम लोअर वॉल्यूम सेट कर देंगे। तो प्रेशर मोड पे अगर 150 से कम आएगा तो वेंटिलेटर अलार्म देगा, या 250 से ऊपर जाएगा तो अलार्म देगा। तो रेस्पिरेटरी रेट, अगर पेशेंट बहुत ज्यादा रेस्पिरेटरी रेट शो करेगा तो हाइपर वेंटिलेशन, CO2 वॉश आउट होगा, CO2 वॉश आउट होगा तो वेसोडायलेटेशन एंड सेरिब्रल इस्कीमिया होगा, तो इट विल बी अ प्रॉब्लम। सो वी शुड कीप रेस्पिरेटरी रेट, जैसे इसका 20 है तो आई लाइक टू कीप बिटवीन 40 to 15। I have already told about tidal volume. Inspiratory pressure, this is very important. अगर pressure 30-32 से ज़्यादा जाता है तो I would like to keep the pressure 35. FiO2, you all know 100 and below we can keep 20-21. Peep high and low should be set कि मतलब 12-13 सन, तो हम 14 के ऊपर नहीं जाएंगे, लोअर में हम 4 से नीचे गए तो हम 4 से 14 के बीच में सेट कर सकते हैं। So we have learned how to start invasive ventilation in hypoxemic child who is not improving on NIV, and how to monitor and how to optimize the oxygenation and carbon dioxide level, how to maintain in the normal range. Thank you so much. So I think everybody is sleeping post lunch. Hello.
Thank you, Dr. Yashwant, for
Thank you,
the
ma'am.
excellent presentation.
Thank you, ma'am.
So, and sparing your time on a holiday. So, thanks a lot. And
Thank you, ma'am.
so now I invite Dr. Anubha Srivastava. She is Associate Professor of Pediatrics at LMN Medical College, Prayagraj. And she will be taking the last topic today, how to wean and extubate a child from ventilator. Over to you, Doctor.
Good afternoon, madam.
Good afternoon, sir. Good afternoon. So, all throughout the day, we have. So, ma'am, can I share? It's asking this will stop others' screen sharing. So,
I have stopped.
You have stopped. good afternoon, everybody. So this is the last topic that we'll be taking today. It's weaning and extubation, and no work is all is well, only it ends well. So all throughout, we have been ventilating the child well, initiated ventilation, maintained his proper blood gases, and now it's time to put him off ventilatory support and bring about spontaneous respiration. So this is what we'll be dealing today. So I'll be dealing the important steps of bringing down the ventilatory support and how to finally extubate the child. So we'll understand the goals of weaning, the physiological concepts, and how to test for readiness and learn the actual process of weaning. So these are the broad headings under which I'll be discussing the topic. So weaning is the transition from ventilatory support to completely spontaneous breathing. So when the child came in a very sick state, he required a full ventilatory support, and gradually when he starts improving, his pathology starts subsiding, we need to bring down his ventilatory support so that he comes to a stage of spontaneous breathing. So that gradual step-by-step process of decreasing the support is weaning. And extubation is, of course, the actual process of removal of endotracheal tube. So if you see the whole journey of mechanical ventilation, weaning is quite a significant, occupies a quite a significant time duration. In fact, it takes approximately 40% of the total duration of mechanical ventilation. So it is as important as a proper full ventilatory support. So what we have to assess before we can decide whether the child is ready for weaning. So we have to see how is his basic pathology, his respiratory parameters, the lung compliance, the resistance that he has to face, the amount of neural drive that he's having, the neuromuscular functioning. And in pediatrics, apart from whatever may be the cause of ventilation, once you have decided to bring down the support on ventilation, you have to also see that other major organs like the nervous system, the cardiovascular system, each and every part major organs are working well, then only you can bring down the ventilatory support. So we have to recognize when the ventilatory assistance is to be brought down, and we have to do this in stepwise manner. So there is a phase of mechanical ventilation, then weaning, and before extubation, we do a short spontaneous breathing trial. So we'll be discussing all these. So when do we actually decide that now it's the time that we can start weaning? So first of all, the oxygenation and ventilation, which involves the carbon dioxide. So these two must be in proper range, or there must be proper oxygenation on the settings that you have kept, and there should not be any buildup of carbon dioxide. Apart from that, the major organs, as I have already told, should be working on their optimal condition. And another important thing is that the protective mechanism of airways, the various reflexes, the handling of secretions, they should be also intact, because if we withdraw the ventilatory support without these airway protective mechanism in place, so the child may again drown into his own secretions. So when these parameters are set and the child has proper oxygenation and the CO2 levels are low, then once the basic pathology settles down, we can start thinking about weaning. So if the child is maintaining oxygenation of above 60% on FiO2 as low as 40%, with and requiring very low PEEP as low as 5 centimeter of water, as appropriate vitals that we have discussed on the first day, the respiratory rate is within normal range, the CO2 is not building up, the dead space ventilation is low, his ventilatory drive is good, respiratory muscles are working well, cardiovascular is disease free, temperature is very important if in pediatric age group, if the child is maintaining normothermia, electrolytes, nutrition, everything, the renal, liver and GI, when all these systems are working well, that is the time we can think about weaning off. And then in local protective mechanism, the child should be adequately conscious with an intact cuff reflex and gag reflex. So weaning, the whole process of weaning, you can do it in either two ways, either in a rapid, which is modern way, or in a slow method. So it basically depends upon the type of pathology for which the child was initially ventilated. So if it is anything severe like multi-organ dysfunction or cardiac failure, so we may require a prolonged weaning process, and we need to be very slow in decreasing the ventilatory support. But for anything short term, like without no multi-organ system failure, short period lasting shock, post-operative stabilization, sometimes for non-resolving seizures, we have to put the child on ventilation. So for this short-lasting condition, we can rapidly wean the baby. So they are supporters of both types of approach. Those supporting the traditional approach say that we should be very cautious, because in certain cases of rapid extubation, there may be more chances of failed extubation, leading to increased mortality and morbidity. And some say that in the modern approach, as many of us who are practicing pediatrics must have seen that many times the child self extubates and does not require re-intubation. So why not do this weaning and extubation in a controlled manner, in a with a rapid approach. So what are the weaning modes? You have learned today about the various modes of ventilation. So among these, the SIMV, pressure support, and TP's assist control mode can be used as weaning modes. So ventilatory support is reduced as patients become increasingly able to resume parts of his work of breathing. So as he takes up more and more of his own breathing, so we can decrease the breaths provided by the machine, or the support provided by the machine. So when we use SIMV as a weaning mode, so the underlying theory is that patient's respiratory muscles would be working spontaneously in the intervals between the machine-driven breaths. So gradually what we do is we gradually reduce the breaths provided by machine in steps of 1 and 2 breaths per minute at a pace that matches the patient's improvement, so that he doesn't tire down and require further ventilatory support. And you can add pressure support ventilation to bring down the load for the spontaneous breath, and this will further decrease work of breathing. For pressure support ventilation, here the patient controls the rate, timing, depth. So it is basically patient triggered. What the machine does is supports each and every breath. So we can gradually reduce the level of support as long as there is appropriate spontaneous respiratory rate and tidal volume is maintained. And you feel that the child is not again going into respiratory distress. So once the pressure support is as low as 5 centimeter of water, the pressure support provided by the machine is negligible, and you can very well assume that child is more or less on is maintaining the respiratory parameters on his own. So this is TPs. In this TPs, you attach this, you can see the figure here. So you can attach the stem of the TPs to endotracheal tube and attach the one end to your ventilator and set the ventilator on spontaneous or CPAP mode. So advantage of using ventilators is that you will be able to use the alarms, the apnea alarms or the low FiO2 alarms. So that will help you to monitor the child. Basically, this is similar to providing small amount of PEEP. So that helps in oxygenation and doesn't lead to collapse of the lung. So once you have brought down the ventilatory support in gradual manner, seeing that at every step the child is breathing comfortably, maintaining his parameters, maintaining his vitals. So that is the time that you can decide on extubation. So extubation is the actual removal of endotracheal tube. And we have to foremost decide whether the primary indication for which the patient was intubated, has it resolved or not. So only once it has resolved, then only we can decide on extubating the child. So the patient should be able of maintaining a stable airway and should have a good spontaneous respiration with neuromuscular adequacy. So again, in extubation, we have to decide on timing, because early extubation can lead to extubation failure. repeated re-intubation, which hence will increase mortality. And on the other hand, delayed time, prolonging extubation will increase, prolonging of ICU stay will increase the cost and again increase mortality. So we have to find an adequate balance on extubating that child. And how do we find that balance? We can find the right time of extubation by giving spontaneous breathing trial to the patient. So what do we do this in this TPs or CPAP, a trial of CPAP at low pressures, as low as 5 centimeter of water, are given to patient initially for short duration like 30 minutes, and gradually if the patient is sustaining that in this short period, suppose if he has seen having no problems, so then we can gradually increase the duration of his spontaneous breathing. And as more the child is able to sustain more and more trials of spontaneous breathing, so the child, we can come to a conclusion that child can be extubated. So it is important to know that we should not have too rapid trials, and it is always practical to avoid such trials and also extubation at night hours, because during daytime there will be more healthcare workers manning the floor, so it's better to do these at morning or evening shifts. So once you have given a spontaneous breathing trial to patient, so you have to see for some objective signs and subjective signs to decide whether the child is sustaining these trials or not. So if he is having tachypnea, tachycardia, hypotension, hypoxemia, arrhythmia, it means the child is not doing well on these trials. And subjectively, you can see for diaphoresis, agitation, anxiety, nasal frailing. So these all also give indication the child is not ready for spontaneous breathing. Hence, the time is not right for his extubation. So once you have, if the child is maintaining, is doing good on spontaneous breathing trial, so you have to see if his vitals, heart rate, respiratory rate, blood pressures are within normal range. Ventilatory support is very low, PEEP as low as 5, PIP as low as 10, and maintaining saturation as FiO2 as low as 40%, then you can decide that the child can be extubated. Also, you have to look for endotracheal tube cuff leak, because one of the common problems that we face in intubated children is the presence of laryngeal edema. So once there is edema, so that the space between tube and the larynx will be decreased, and hence there won't be any sound of air passing through that space, and you won't be able to hear any sound of leak. So if you hear a leak, it means that there is no edema. So the caliber of airway is well enough to sustain spontaneous breathing, and the child can be extubated. So before you actually extubate the child, you should stop feed 6 hours prior to extubation, and definitely stop sedation at least 2 hours prior, because a sedated child will never be able to have spontaneous breathing. So it is always good to stop sedation adequately before extubation. So there are various predictors to decide, but none of these parameters are infallible in predicting success of extubation. We have checklist also to tick off before extubating the child, but it is always the clinician who is the best judge to decide whether the child can be extubated or not. So once you have seen the patient, seen his parameters, and you decide on extubating it, first you should stop or taper sedation. If the child is on longer acting sedatives, you can put him on shorter acting sedation. Assess the consciousness and muscle power of the patient. Look whether he is following commands, or in younger child, you can see for hand grip, neck holding in older children. And if the child is an infant, you can see for its limb movements, whether he's kicking the air. So you can decide his muscular power, and also assess for the accumulation of secretion. There shouldn't be any. Assess for peritubal leak that we have already discussed, and you decrease ventilatory support and extubate the child. So at extubation, first the patient can be kept in semi-Fowler or high Fowler position, if possible. Otherwise, a child can be kept in any comfortable position. You explain the procedure to the attendant. Pre-oxygenate the patient with manual ambu bag and with 100% oxygen. Suction the patient mouth and pharynx and reoxygenate after suction and clear the airway as much as possible. Loosen the tape surrounding the tube. Then you squeeze the resuscitation bag while deflating the cuff. So to force secretions into the mouth or above the cuff and suction it again. Oxygenate and then hyperinflate the patient. So what will this do? This will bring about maximum abduction in the vocal cord. So they will be maximally separated. So now when you withdraw the endotracheal tube, there won't be any injury to vocal cords. So after you have removed the endotracheal tube, administer the same fraction of inspired oxygen on which the patient was prior to extubation. Monitoring is very important. Even if you have extubated, you should keep on monitoring and encourage child to cough or take deep breathing and auscultate his chest, especially in the neck area, to rule out any edema. Monitor the patient next 1 hour is very critical. Although not always necessary, but if you think so, you can get a arterial blood gas measurement to see the child is doing well on spontaneous breathing. So this is the whole algorithm that we discussed now. So extubation is said to be successful if there is absence of ventilatory support 48 hours following the extubation. However, it is failed if the child is not sustaining on spontaneous breathing trial and needs to be reintubated, or we lose the child within 48 hours following extubation. So what can be the causes of extubation failure? It can be abnormal respiratory mechanics, the pressure building, the expiratory phase, and a prolonged duration of mechanical ventilation can also lead to extubation failures. So we have to decide on an adequate time of extubating. Hemodynamic instability, consciousness level, inability to manage secretions, as I've already told, other major organs and local handling of secretions are very important in deciding the extubation time. And then there may be some rare causes like genetic and metabolic abnormalities. A short note on tracheostomy, because some patients who require long-term prolonged ventilatory assistance, it is better to put a tracheostomy tube there rather than keeping him on prolonged endotracheal tube, because but however tracheostomy should be performed only after initial stabilization and if you think that the patient will benefit from the procedure. So post extubation there are various scores to decide whether the child will be doing well, but mostly if you have a score of more than 7, then the child may require reintubation. A short word on post-extubation airway obstruction, because as I told you, this is a very common problem. As high as 25% of patients may face this. However, with proper ventilatory techniques and monitoring, the incidence of post-extubation airway obstruction can be brought low as 2%. So good monitoring while the child is on mechanical ventilation is very critical. This is seen most commonly in smaller age children in whom larger endotracheal tubes are used, and multiple attempts on extubation or airway manipulation is done. Inadequate sedation is a very important cause, because then the child keeps on fighting while on mechanical ventilation and leads to injury to his airway and hence post-extubation obstruction. So there's a role of steroids. It reduces the incidence of post-extubation stridor, although it doesn't significantly reduce the reintubation rate. So dexamethasone dose of 0.15 to 0.5 milligram per kg can be given. Multiple doses, 3 to 4 doses can be given, but preferably it should be given 12 to 24 hours before extubation. So once you have extubated the child, it is better to put the child on supplemental oxygen. So you can give it by nasal prong or face mask. In most patients, this will suffice, but for the kids with a higher risk of failure, it is better to put him on non-invasive ventilation. And in that case, you need a close monitoring for next 24 to 48 hours and look for airway obstruction, respiratory distress, and also hemodynamic stability. So non-invasive ventilation after extubation appears beneficial in sick patient because it improves survival and lowers mortality. It also reduces risk of nosocomial pneumonia, because that can further lead to more need of ventilatory support. So in sick patient, it is better to decide on non-invasive ventilation. So apart from obstruction, other complication of extubation are transient increase in blood pressure and heart rate, laryngospasm, laryngeal edema, hemorrhage if you haven't been very cautious in extubating the child, or trauma to vocal cord or paralysis. So to conclude my talk, the goal for weaning from mechanical ventilation is to liberate the child from ventilator so that he can sustain an independent breathing, bring down the support gradually, although there are various indices, but it is better that you decide it clinically, and you can give spontaneous breathing trial to assess the readiness of weaning. SIMV, pressure support, and TPs are the common modes of weaning. And post extubation airway obstruction is most important cause of extubation failure, so you should be very cautious, and during your mechanical ventilation you should be monitoring child well to avoid these complications, and you can use steroids. These are my references, and I thank all the contributors. Thank you.
Thank you, Dr. Anubha, for explaining everything so beautifully.
Thank you, ma'am.
Thank you. And my special thanks to all the speakers who, despite being a holiday today, they all accepted my invitation happily. So thanks to all the speakers of today's session. So we have seen that Dr. Kavita intubated the child, and Dr. Thapar, Dr. Yashwant, Anupma, and Manisha managed the child, and now Anubha has successfully extubated the child. So everything is good and everybody is happy. So today's session, we end it here, and tomorrow again we will start at 12 noon. And tomorrow we have a mixed bag of topics like shock, MIS, so all important topics. So we will again meet tomorrow at 12 noon. Thank you everyone, and thanks all the participants also, because this was a holiday, and despite that you all attended this training program. So thank you everyone.